Okay, perfect. Well, let's go ahead and get started. Welcome everyone, and thank you so much for joining us today for the second annual North Sound Race and Health Equity Conference. We are so grateful that you have decided to share your time with us on a Saturday morning to talk about these important issues. My name is Erica Gadzik, and I'm a family physician at North Sound Family Medicine and Family Care Network in Bellingham, Washington, and I'll be serving as the moderator for today's event. I have no financial disclosures. I want to start off by giving a huge thank you to all of our sponsors who made this event possible. We're here thanks to the generous financial support of Chuckanut Health Foundation, Family Care Network, North Sound ACH, Skagit Regional Health, Northwest Washington Medical Society, and Peace Health, all of whom have contributed to support us in making this a free event accessible to all. I'd also like to give a special thanks to the many individuals who volunteered their time and energy in the planning and execution of this conference. It has been a team effort with contributions from so many individuals and so much volunteer time. So thank you to those who have helped make this happen. As we get started, we welcome you to let us know who is in our virtual waiting room by sharing your name, your preferred pronouns, and your organization in the chat box. Just so you know, this morning's conference will be recorded and a copy of the recording will be sent out afterwards to those who are registered. Speakers will have a few minutes for questions at the end of their session. And so keep in mind, if you do have questions, you can put those in the chat and they'll try and get to those. In the meantime, please use the chat to ask questions, share comments and reactions. It's nice to have a community conversation going on in the chat as we're tuning in for all this important information together. As a quick reminder, we're meeting today from 9 a.m. to 2 p.m. with a break for lunch at 11:30 a.m. This conference is approved for 4 hours of free CME. And if you want to receive CME or continuing nursing units, please click on the link in the chat box. This is how we're taking attendance. And it also has the required evaluation in order for you to get that CME credit. And we'll be sending this out again at the end of the day and via email following the conference. We know you have all spent time on Zoom, so we're now going to switch things over to Natalie Esparza with North Sound Accountable Community of Health to review some Zoom basics.
Like I said, thank you all for joining us so much. To get us started, we have a few Zoom basics, and we want to just make sure that everybody has the same foundation. So I want to direct everybody to the lower part of your Zoom screen where you should see a bar with various different buttons. Starting in the low left corner, you should see a microphone that says mute or unmute. And we're going to ask that unless requested by any of our speakers that you remain on mute. If any members from our tech team notice that somebody is unmuted, we have the ability to mute you ourselves, so don't be surprised if that happens throughout the day. We understand that mistakes happen, so no worries. Directly to the right of the mute button is the video symbol. And if you are comfortable with or without video, feel free to use that. You're more than welcome to step away, take deep breaths and breaks throughout the conference since we are meeting until 2 today. Let's see. The next button that you'll see is the little chat bubble. And if you'd like to respond to anything that one of the speakers say or give kudos throughout the day or share resources, please use the chat function. And we're more than happy to share those resources with everyone also. There's also you will see a raise hand function for our speakers to call for questions, or if you need any technical support, I can send you a chat as well to make sure that it wasn't a mistake and we can get that taken care of right away. Lastly, we will also be assigning people into breakout rooms today, and we're going to need your help to do this. So if you could please change your name and add a parentheses after your name to include the breakout group that you will be joining us in. For example, A, environmental justice, B, type 2 diabetes, C, DEI in the outdoors, and D, language interpretation. All right, and that is all for me. I'll pass it back to Erica.
Thank you so much, Natalie. If anyone has questions or concerns during our meeting today, please feel free to chat Natalie. She's a wealth of information on how to navigate the Zoom logistics. So now that we have some housekeeping items out of the way, let's turn to the real reason that we are here today. Last year, we hosted the first annual North Sound Regional Race and Health Equity Conference. This conference grew out of the realization that as healthcare team members, we are uniquely situated to promote health equity in our community. We begin with a discussion of socioeconomic determinants of health in Northwest Washington, a walk through the history of racism in Whatcom and Skagit counties, and an introduction to implicit bias. We talked about strategies for recruitment and retention of BIPOC individuals, and we started a scholarship with the explicit purpose of supporting Black, Indigenous, and students of color and their path to pursuing their degree in health professional fields. 1 year later, health disparities persist. As we enter the third year of the pandemic, CDC data makes it clear that some members of the community are hit harder than others, both from their risk for infection and their risk for serious complications. Data shows that throughout the COVID-19 pandemic, BIPOC people have been at much higher risk for illness, yes, but because of systemic racism, the risk for hospitalization and death are also much higher. Oh, I apologize, guys. I'm having some computer malfunction here. Bear with me for just a moment. While I'm fixing this, I'd like you guys to put into the chat box one thing you're thinking about or wondering about, interested in learning today. All right, our intro is going to jump around a little bit, be slightly out of order because my computer is deciding to throw a few curveballs our way, but we're going to roll with it this morning. As we move forward, I'm going to start with some definitions of health equality versus health equity. So health equity is the absence of avoidable or remediable differences among groups of people, whether these groups are defined socially, economically, demographically, or geographically. And so while equality means that individuals or groups of people are given the same resources or opportunities, equity recognizes that every person has different circumstances. It allocates the exact resources and opportunities needed to reach an equal outcome so that everyone has the opportunity to be as healthy as possible. Health disparities refer to differences in outcomes or disease burden in different groups. This could also be differences in disease prevalence, insurance coverage, access to care, or quality of care received. And it's the lack of health equity that causes those health disparities, those differences in access and those outcomes. Today, it's the lack of health equity, which means that some of our patients don't have access to the same care and outcomes as others. So today, we gathered to learn what we can do to promote health equity and reduce healthcare disparities in our own backyard. You have probably heard the Edward Demings Institute quote that every system is perfectly designed to get the results that it gets. Our current system is not meeting the needs of all of our patients. And as a result, our Black, Indigenous, and persons of color patients have worse health outcomes. And so it's becoming increasingly clear inaction is the path towards reinforcing the status quo. As leaders in healthcare, we have the ability to work together to change this. As you're listening to our speakers today, I implore you to ask yourself how you can take that next step to move yourself off of the sidelines and work towards racial equity and into a more active role. Is it educating yourself further? Is it finding the courage to speak up the next time you witness a microaggression? Is it learning what a microaggression is? Is it shifting the way that you think about a patient who's been unable to take their medications consistently and asking yourself which systemic factors may be complicating their care rather than jumping to judgment? Is it finding a way to make your office feel more safe and inclusive for people of color? Or is it advocating for better translator services in your clinic or hospital and more accurate DEI data collection in your hospital system? Or is it contributing to supporting the next generation of medical providers and leaders in our community through the North Sound Health Equity Scholarship? No matter where you are in your understanding of race and health equity, my hope is that today we can build on the collective mindset that we all have the power to take steps to address racism and improve health in our community. As we begin today, I want to humbly take pause to acknowledge our Coast Salish community. We acknowledge with humility that the land of the North Sound region today is the territory of the people of the Salish Sea. Their presence is imbued in the waterways, the shorelines, valleys, and mountains of the traditional homelands of the Coast Salish people since time immemorial. This is the land acknowledgement of North Sound ACH, and it is one way of us taking a moment to acknowledge what we are working towards together today and the place that we sit. This conference and all of you here today are part of the shared commitment to an ongoing journey of tribal and equity learning that the North Sound Accountable Community of Health launched in 2017. This is a continuous learning journey and one that will be deepened today by the work and involvement of Dr. Dakota Lane. We bring this land acknowledgement to life when we reflect seriously and act with humility to ensure that all of our healthcare environments and interactions are welcoming and bring about healing. And with that, I also want to say that race and systemic racism can be hard to talk about. In preparation for our conference today, I'd like to introduce several concepts that can be helpful when discussing race and racism. First, I ask you all to come into today's meeting with a growth mindset. We are works in progress. We are not fully formed humans. We all have room to grow, to learn, to evolve in our understanding of the world around us. Second, a discomfort disclaimer. If there's anything that we talk about today that makes you feel uncomfortable, I encourage you to sit with that, to think about why it makes you feel uncomfortable, maybe even to lean into it rather than backing away from that feeling. It is okay to feel uncomfortable, and that can be a sign of growth and learning. And finally, if you're a person of color and any of this information is triggering to you, please feel free to take a break and step away as needed. So with that, it's my pleasure to introduce our first speaker of the day, Ling Sao.
Hi, folks. I am going to go ahead and share my screen, and we're going to get rolling on a real good time. And by a real good time, I mean a whole lot of information. And in just a hot second, I will get started because I am arranging my chat box in case any questions pop up and you want to pop those into the chat, we'll hit those. So today I get to talk to you about data and history. And just a little bit about me, my name is Ling Sao. I use she, her pronouns. I'm a Chinese American. I grew up here in Whatcom County, and I have been working with the Checknut Health Foundation on the founding of a Whatcom County Racial Equity Commission here in our community. And I would love to just start with what we are doing here today in the next 20 minutes. It is my privilege to take you through some of the narrative threads of our community. You know, we are going to look at the history of this place and where we reside. We are going to hold that information in our hearts today, and we're going to look at how those threads are coming together with some data across, you know, a family that's having a child here in our community. I had a good chat with a friend of mine a few weeks ago about the word heavy, because they shared a poem and they were like, this is really heavy. And I was just like, all right, sometimes we experience something that's heavy, right? And it weighs us down. And I'd love to offer this, you know, as we go through this day. Heaviness is an invitation. It's like lifting weights, which is not a thing I've done in probably more than a year, and I'm comfortable admitting that. When we lift something heavy, sometimes we have to take that moment where we recalibrate, right? We pause, we feel that heaviness in our bodies, we shift how we hold ourselves, and then we lift the weight. And in doing so, we get stronger. Our bodies adapt, we grow. And now that lift may not necessarily always feel easy, or even easier the next time we try and do it, right? But even in that heavy, we know what we're capable of, and we know that we can hold the heavy, we know that we can rise, and we know that we can get stronger than we once were. So, you know, my hope in all of this for today is that y'all get pumped. Hashtag metaphorical leg day. Also, how do you know your presenter's a millennial without telling me your presenter's a millennial? So this is going to be an awesome day of learning, friends. And we are going to start with our history. And so I'd love to center us in the words of Grace Lee Boggs, who is a huge inspiration for me. You know, we have an opportunity when we learn. We have an opportunity when we look at our history. We get to choose whether we act critically, whether we think about it critically, or whether we distance ourselves from it. And I'm going to ask you to kind of lean in today. Here is a very, very abridged racial history timeline. If you're unfamiliar with the Bellingham racial history timeline, it was compiled by a couple of Western students who wish to remain anonymous, and I totally respect that, even though I think they're really awesome. It is a fantastic resource with archival documents and images and videos, and this is a snapshot pulled from their research and their timeline. It's also pulled together from the C2C's documented timeline for our area, from community to community, and honestly from experiences from my own childhood living here through the 80s and 90s. You know, I was a child in the Meridian School District that remembers a cross being burned on the Pole Road. I remember when one of my classmates threatened to hang another student, and then there were nooses in our parking lot. You know, I could talk us through each of these events one by one, but what I'd really like to share with you right now is this. Each of these orange boxes represents a decision that was made by the government. It was a decision to colonize this area. It was a decision to not allow slavery and to also outlaw free Black individuals under pain of nightly lashing. And that is because being anti-slavery and being anti-Black are not mutually exclusive. Boarding schools, Chinese expulsion, the mayor of Bellingham giving a Grand Dragon of the Klan a key to the city, not enforcing treaty rights, redlining, ICE raids, all of those are policy decisions. There were choices made by those seated in positions of authority. And each of these in mauve, these were things that were not deemed criminal. There were socially acceptable behaviors, and that includes lynching, expulsion, mob violence, the expulsion of the South Asians from our community, Klan parades, and the practice of sundowning, which is driving people of color outside county limits and leaving them away from home. And sometimes history can feel like it's a million miles away from us. And I'd love to reframe this a little bit because, you know, in this world of Snapchat, TikTok, being able to take a picture with your iPhone, when a photograph is in black and white, it feels like it's a million miles away. You know, the Costco doesn't even develop 35mm film anymore. I checked. And so I want to measure time in a slightly different way, and that's through cultural icons. Why not? So looking at this timeline again, in the 1920s and the rise of the Ku Klux Klan in the United States and here locally, Barbara Walters was born in 1929, which is the same year the mayor of Bellingham gave a Grand Dragon a key to the city. If we have loved ones in their 80s and 90s who lived in the United States, they were living through a time where 15% of white adult men in America were members of the Klan. Redlining was established in Whatcom County, which is that practice of literally drawing a red line on maps and not allowing communities of color to live in those areas. Redlining was established in the 1940s. Nancy Pelosi was born in 1940, my friends. Japanese internment was in 1942. That's the year Joe Biden was born. Sundowning is only one Bill Nye away from us when it started. And it continued until I was born in a house on the Aldrich Road out in the county. 1973 was the closure of the last boarding school in the United States, and that's a Kristen Wiig away. That cross burning that I mentioned is only a Justin Bieber away. In 2003, hold on, I advanced too fast. In 2003, when those nooses were hung, my sister was the homecoming queen and the ASB president at my school. These things are not so far away. You know, when we look at the ICE raid at Yamato Engine, that's when Councilmember Kaylee Galloway was getting ready to graduate from high school. When we think about the Fortress of Faith putting Islamophobic rhetoric on the airs, that's the same time when Adele's Someone Like You was the #1 song. And I also want to talk a little bit about Emmett Till. You know, before we dig into the data, I just want to take us back to that date of that year of 1941 when Emmett Till was born, because I've been thinking about this a lot, and especially with watching the State of the Union address recently. Emmett Till was born in 1941, 1 year after Speaker Pelosi and the late John Lewis, 1 year before President Biden, making Emmett Till the same age as two of our current national leaders. 14-year-olds have a whole world of potential ahead of them. In 1955, this young man was robbed of that. Who's to say what he could have done? Or, could he have served alongside the Nancy Pelosi's, the Joe Bidens, the John Lewises? We are only a few generations away from this. We are only a few generations away from settler contact on the land that we're currently residing on. We have neighbors who lived through this history. We ourselves are part of a living timeline. And these threads of history weave into our lives, impacting people every day. My next slides are related to some data. And a lot of this you may already know, some of it may be new. As we walk through it together, let's just remember that we're woven into the tapestry of this history like every single person this data represents. So I just want to set a baseline for us. Let's imagine the life of a family about to have a baby here in Whatcom County. We're going to talk about this. This chart may look familiar to most of the people on this call. I know the room. Y'all are awesome. This is looking at the determinants of health, and honestly, access to care and quality of care for someone receives in a lifetime is only part of an individual's health story and their health outcome. Much more goes into determining someone's quality of life and the length of their lives. There are additional underlying factors that influence health. It's jobs, it's housing, it's finances, it's education, it's their physical environment. It is their social support. It's the air they breathe. Systemic racism has resulted in race being a determinant of health, with persistent racial disparities in all aspects of health, including housing, education, healthcare, employment, worker protections, criminal justice, climate impacts, food access, and technology. And the Center for Health Progress has reported that data shows race, income, and zip code have a bigger impact on health than behavior or medical care. And this is pulled direct from our own resolution affirming racism as a public health crisis, which I know this language also came direct from the CDC because I remember the drafting process of these resolutions. The data shows that racial and ethnic minority groups throughout the United States experience higher rates of illness and death across a wide range of health conditions, including diabetes, hypertension, obesity, asthma, and heart disease when compared to their white counterparts. So let's get into the data. So we have these folks about to have a baby. Let's consider the median household income if finances and financial stability are part of those determinants of health. People from racial and ethnic minority groups have lower incomes and experience barriers to wealth accumulation and carry greater debt. Such challenges may make managing expenses, paying medical bills, and accessing affordable quality housing, nutritious food, and reliable childcare difficult. This is the median household income of Whatcom County compared to the national statistics around what the median income of the average income for these different communities of colors are. The difference from our white community, from our median household incomes is right here on a piece of paper. This is just me sitting down and doing the math by percentages. AI and AN, American Indian, Alaskan Native, and Native Hawaiian Pacific Islander. I just saw you, Elizabeth, in the chat. I got you. That's acronyms. Acronyms are, I'll work on de-acronyming as we go too. Just so we know, the survival budget in Whatcom County for a family of 4, so that's 2 adults, 1 toddler, 1 infant, in 2018 was $66,480. So prior to the pandemic, 1 in 4 homeowners and 1 in 2 renters were spending more than 30% of their income on housing. So half our renters. there are severely cost burdened households spend more than 50% of their income on housing. Prior to the pandemic, that was 17% of our Whatcom County residents. And how that shakes out in terms of our communities of color looks a little something like this, which means that our Hispanic households have a 4% higher rate of being severely cost burdened. Our Asian households are 4% more, are experiencing 4% more severely cost burdened homes than the homes of their white neighbors. And it just keeps going up with our Pacific Islander communities and our Black communities. Now, imagine these parents if it just had a baby. We know that perinatal mood and anxiety disorders are one of the most common complications of pregnancy. Every year in Whatcom County, 2,000 babies are born. And 20% of new gestational parents report symptoms of perinatal mood and anxiety disorders. That number goes up to 50% when we look at parents who are people of color, who are low income, who are adolescents, who have experienced depression or anxiety before. And why does this matter? Because if left untreated, this impacts the health of the parent, it impacts the development of children, and it impacts parent and child relationships, which we know in child, youth, and mental and behavioral health that parent relationship is an essential domain of prevention for behavioral health issues in the future. Locally, 90% of the families who participated in the Help Me Grow survey recognized symptoms of PMADS. 37% of English-speaking families and 20% of Spanish-speaking families knew where to find support at the time. And only 15% of parents experiencing PMADS actually sought support, which left 340 parents who may need help. So let's consider life expectancy at birth. Now, life expectancy at birth is an indicator of health outcomes. Life expectancy at birth can be associated with a number of health factors, including improved the living standards and lifestyles, education, access to quality healthcare and services. We know that in our community, our American Indians and Alaskan Natives experience a lower life expectancy at birth by comparison to other racial groups. The average Whatcom County life expectancy at birth is 80.85 years. And yet the life expectancy of an Indigenous baby born in the same hospital is 12.14 years less than their white neighbors. And for migrant farm workers, this is from national data, the average life expectancy is 49 years, which to me is honestly just unacceptable. I'm just going to say that on a personal level. So looking at K readiness, which is kind of a proxy data point for all the goodness that we get for kids coming into school. 1 in 2 of our children arrive kindergarten ready. That number goes down to 1 in 4 when we're talking about children of color. When we look at, sophomores experiencing and reporting depression from our healthy youth surveys, this is what that looks like. We have higher rates in our communities of color. 38% of Whatcom County sophomores report experiencing depression. And yes, this is pre-COVID, Devon, 100%. Devon's in the chat being completely on point about this. And even in 2018, we were 4% higher than the Washington state average in terms of reporting suicidal ideation. And the rate of suicidal ideation is 3 to 4 times higher if a student is not heterosexual. Now we know education can be a pathway to economic success and opportunities. We see lower graduation rates for some of our communities of color and our communities who are English language learners or from low-income families. And that can be an indicator of how the system is ready to work with these students. It can also be an indicator of, no, honestly, it can be an indicator of how the system is ready to work with these students, as well as what resources and access they have available to them as they go through their education systems. Now this whole thing, this whole shebang is just mapping the trajectory through graduation. And it is no way comprehensive of the entirety of a human experience. It doesn't capture that 82% of Whatcom County sophomores do not eat the 5 servings of fruits and vegetables a day, or that lower income and more diverse neighborhoods are also our food deserts. This doesn't take into account the potential of communities of color. You know, the Hispanic population nationally has a $1.5 trillion national buying power, which is greater than the gross domestic profit of the entire country of Australia. This doesn't take into account that Asian and Hispanic communities have experienced the fastest economic growth since 2000 at 267% and 212% respectively. This doesn't take into account that Sunita Eisenberg founded Whatcom Waves, an all BIPOC youth soccer team, or that J.R. Nelson, a former NFL player, is up in Linden training young people. It doesn't capture the excellence of Tazi Muhammad Ali, who founded Whatcom Care and is advocating for since time immemorial curriculum, or Rosalinda Guillen, the ecofeminist who's here with Comunidad to Comunidad, receiving a James Beard Award for her advocacy and the advocacy of that community, or that Jason McGill in Northwest Youth Services will be working with Away Home Washington as Whatcom County joins the second cohort statewide that is trying to ensure that all of our youth and young adults are housed, or that Dr. Wu, who's on this call right now, was a powerful champion or a catalyst for getting our community vaccinated. You know, these numbers can't capture what it feels like to watch Jade or Aida dance at rallies in 2020, or what it felt like when Christina Michelle Martins and Skip Williams were elected the first Black people to serve on Bellingham City Council. Or Skip's daughter singing, or the fact that his son Taj is actually at the Whatcom County Cultural Arts Festival right now spray painting, and his murals are all over downtown. It doesn't capture the lyrics that the rhetorician writes, or the sound of the Harris twins singing, or the richness of conversations with Terrence T.J. Morris, Shirley Williams, Kumbia Jiboye, Christina Spina, Alini Prata, Carrie Blackwood, Janice Farmer, Nasreen Mughal Burrows, Batul Abdi, Rita Jefferson, Deja Hayward, Dee Dee Davis, Monica Kohler, Devon Nixon, Harmony Devaney, and so many beautiful love warriors in our community. I could celebrate this community for hours because of the excellence in it, and the wisdom and the accomplishments of our community members of color. And I invite you to also hold that in your hearts as you consider the data and the hard and the heavy, because there's so much beautiful in this community. So thank you so much for giving me the time that you have today. I think that I just want to leave you with this last image, which is from the vigil that we held. And all of the images, with the exception of that photograph of Emmett Till, were for a vigil that we held a year ago for the Asian and Islander women who were shot in Atlanta. And I also want to leave you with the words of Ray Soriano, who spoke that day. My liberation is your liberation. My liberation, my justice, is your liberation and your justice. So as we work, as we create ripples together, just like this history has created ripples that we are dealing with right now, remember that we are woven in an incredible fabric of this community, and that you're here today to commit to doing the lift. You're committing to rising together and to holding the heavy. So thank you all.
Thank you, Sue Ling, for your powerful words and for taking the time and energy to find a way to kick off today's visit. You know, I think so often in healthcare, we focus on the data and the numbers, and those pieces are important. And also it can be easy to get lost behind the fact that we don't always really spend time holding the heavy of the fact that there are people and stories and our community members and so many folks in our community who are the people behind these numbers. So thank you for tying those together and for a really creative way and showing us just how woven into our recent history some of these events are. thinking about the data, one of the interesting things that we ran into when we were working with Sue Ling and her work on the Whatcom Racial Equity Commission to figure out what the numbers were and where were we falling short in our communities, we realized we don't have a lot of the data that we need. We don't have enough time and energy going into collecting DEI data focused on diversity, equity, inclusion, and where we are falling short. And as a physician, I'm always looking for numbers to say where are our holes and what can we do to address that. And so this next piece is going to highlight some work that Skagit Regional Hospital is doing and their DEI team. It's my pleasure to now introduce 3 individuals from Skagit Regional Health who are going to be sharing some of the DEI work at Skagit. First off, we have Dr. Melinda or Mindy Mantooth, an internal medicine resident at Skagit Regional. She is passionate about health equity and enjoys leisurely adventures with her wife and pack of dogs. Angel Abbott is the Director of Patient Access and Interpreter Services at Skagit Regional Health. She's a busy mom of 3 kids, and her hobbies include attending kids' sporting events, spending time outside in warmer weather, and spending time with family and friends. And finally, Dr. Randy Ceballos is a second-year internal medicine resident at Skagit. He recently moved from Florida to Washington to start his career on the West Coast, and in his time outside of the hospital enjoys live concerts, art shows, and hiking. All right, turning it over to the Skagit team.
Thank you so much. Thank you for having us. Okay, so I'm here to talk about Skagit Regional Health and what we're doing for diversity, equity, and inclusion, specifically our Diversity, Equity, and Inclusion Committee. Perfect, thank you. So our agenda here is to talk about what our pathway is to diversity, equity, inclusion, or DEI. I'll be using DEI because it's kind of a mouthful. What the committee structure looks like and its work groups, kind of the functionality. And then Angel Abbott, our Director of Patient Access, will be talking more about our DEI data collection and the data work group. And then Dr. Randy Ceballos, my colleague, resident colleague here, will talk about cultural sensitivity and interpreter services, data collection. Next slide. All right, so our pathway to DEI. So at Skagit Regional Health, one of the reasons I chose to come here for residency is because of the diversity. They really prioritize, especially in our graduate medical education, diversity among our peers. And Skagit really does recognize that diversity, equity, inclusion is an integral part to not only our organization's guiding principles, but to the delivery of excellent healthcare. And that helps keep us on our path to our true north, or the commitments that we have to our patients. And of course, all of our employees, medical staff, and contractors, agents have the responsibility to treat others with dignity and respect. And Skagit really makes that a priority. Next slide. So the DEI, the committee, the structure is, it's a subcommittee of our Executive Quality Oversight Committee and responsible for setting and driving our diversity. And of course, Skagit Regional Health adheres to equal employment opportunity policy, although we strive to be much more than that, than the bare minimum. Next slide. So the DEI committee structure, we have committee chairpersons kind of at the top overseeing everything. And then it's comprised of four work groups. So there's a data work group, a listening work group that collects data, a policy work group, and then a training work group. Our committee has been in place for over a year. The larger committee, including all of the work groups, meets about quarterly. There's been a couple of hitches with COVID, of course, but that is the goal. And then our monthly meetings, we hold those for our individual work groups. And then it's made up of 30 physician and non-physician members in the organization. And this is just another slide to kind of show the structure. Next slide. So our timeline here, we're kind of in the planning and development stages, starting to implement policy and also computer-based learning to help increase diversity, equity, inclusion, education in our organization. So we did change some categories in EPIC so we can collect data, and Angel will talk about that more in a little while. What else are we working on? The DEI computer-based learning. We have started that, and of course, working on our policy as well. Next slide. So these are our graduates from last year. And of course, as I said, Skagit really does support diversity. They really do prioritize it. And it makes for a really collaborative and great working environment. Next slide. Okay, so a little bit about the work groups. Next slide. So policy work group, the goal is to create an overarching policy for diversity, equity, and inclusion, to make sure that the policies that we have now are aligned with diversity, equity, inclusion, and also to create new policy to improve upon it. We always have things to improve upon, of course. So what we've completed is getting an overarching policy. We're gathering feedback from DEI leaders and DEI committee, and then reviewing related policies and procedures. Next slide. We also have a listening work group, the goal being to gather feedback from staff and community on DEI related topics. And really what we're working on here is a thought exchange question to our employees. How can we better live our values of diversity, equity, inclusion, kind of seeing what comes back to us. Next slide. And then the training work group. So implementing diversity, equity, inclusion related training for staff. And so we do have that computer-based learning. It's actually quite good as part of our resident requirements. We did go through it, and it's pretty excellent actually. And so that is the training work group. And Angel will talk more about the data collection here.
Good morning. I'm Angel Abbott, Director of Patient Access and Interpreter Services for Skagit Regional Health. And the next slide, please. I'm going to talk to you a little bit about our data work group. So this is, our goal was to collect more accurate data within our EHR system. And what we've done is we reviewed existing race and ethnicity categories within our EHR. Our committee approved new categories for us. And then we went live in our EHR with the new categories, and we conducted frontline staff training for them to understand how to more accurately enter real data into the system, so then we can pull additional information out. Next slide, please. One of the big things we did was we made these fields hard stops within the EHR, so staff cannot bypass them. And then currently we're developing reporting so we can track and trend categories of unknown or other. And then we can provide additional education to front-end registrars who are still using those as an answer to those questions. Next slide, please. We thought it was really, really important as we were doing the frontline training is why does ethnicity and race need to be collected? So I'm going to share some of the key points that we went over during the training for ethnicity and race. Knowing the why helps with understanding the importance of entering accurate data within the system. And some of the areas we touched on were explaining health equity and why it's important, providing high quality of care to every patient is important, and this is unable to be provided if any disparities exist. For us to identify these disparities, we must be collecting the ethnicity and race, and in doing so helps identify the difference in care and developing targeted interventions. Next slide, please. And then we thought it was also important to put out there, what is the difference? So ethnicity is more broadly defined as a large group of people classed according to common racial, national, tribal, religious, linguistic, or cultural origin or background. And race is defined as a category of humankind that shares certain distinctive physical traits. Next slide, please. So as you can see here, this is the list we previously had in our EHR system. They were quite long. And then after the committee approved the new list, go ahead and go to the next slide, please. You can see we've pared this down quite a bit. And our decision to pare it down is we followed the Washington State race and ethnicity recommendations. And that's how those decisions were made. Next slide, please. Okay, and Randy will go ahead and share with us some information on cultural sensitivity and interpreter services.
Wonderful. Thank you so much for the smooth transition. So yes, I'm Randy Ceballos. I'm a second-year resident here at Skagit Regional, and my talk touches on the control sensitivity and the interpreter services data collection. So we can transition over to the next slide, where I want us all to kind of have be in this mental space of remembering that every individual that we treat or encounter has their own set of morals, values, beliefs. And it is when we fail to make an effort to understand those same values and beliefs that we create an environment of fear, distrust, and that ultimately ripples out into negative health outcomes that we want in the community. So by bridging that gap, we're able to really reach the community and alter those outcomes. So understanding that while we talk about data collection and these generalizations that we're able to make with the data, it is important to remember that we're talking about individuals with their own set of beliefs, okay? So it helps to illustrate kind of who we're talking about, right? And the who is a pretty big question, but a good starting point is looking at our local data. So looking at the numbers here for Skagit County, we're talking about a community of roughly 130,000 individuals. Now, this community is pretty even split in between people that identify as male or female, 51% female. And we can even further break down this data into race and ethnicity. 74% of the population being white, and the rest being Black, Native, Asian, Islander, Hispanic, making the biggest second demographic there, or people that identify as biracial. Now, I want to draw your attention over to the top right of the slide. It's a little busy, but it breaks down the age of this population, and the bulk of it consists of the group of 18 to 64, comprising 57% of the population. This is pretty important because it captures the multi-generational demographic that we will focus on today, and we'll break down a little further in the next slide. Yes, so here we see that same 18 through 64 range, or 18 plus here in our community, being able to break it down into the language that they speak at home. Now, 85% of the community is strictly speaking English at the home. However, that leaves 15% that are either bi or multilingual. Now, these are the communities that we look at when it comes to the dependence on the generational differences in language and education. These homes depend on one another in terms of the language to communicate with other members of the community. They depend on the intergenerational education in order to better understand what's happening in the community. And for this is important to highlight because it is the people that we see more often, and we need to reach out, cross that bridge or that gap in gender or cultural differences. Now, something that was really important and interesting for me to have on this slide was in the bottom right, the breakdown of the languages spoken in the Mount Vernon High School. Okay, so this is our up and coming generation, and we see that 41% are white, while a big bulk, 51% Hispanic, and the other 9% between Asian, Black, and Hawaiian. And this shows just the fluidity of the demographics that we're dealing with, and the fact that we may be acting on a snapshot of data, but these are changes and policies that could have an effect that would ripple through multiple generations, as illustrated here by this data. So what are we doing for these communities, right? In the next slide, we'll see one of our main approaches, which is providing interpreter services. Now, this is, to me, a critical part in delivering healthcare. Not only does it show that us as providers or as healthcare professionals are willing to go the extra mile to just understand and meet people at their level of comfort, but it also shows how open we are to change. And that's something that can make other people uncomfortable. Through the use of interpreter services, people are able to communicate more freely and clearly, using words that perfectly or more accurately describe what they're going through, rather than going through makeshift words to kind of not be as accurate with their needs. And this reduces a lot of the obstacles that we see in healthcare. Now, I wanted to note here that the interpreter services are not only beneficial or recommended for those that do not speak English, but also those that have limitation in the English language as well. So there is always a role for these services to be used. Now, in the next slide, I'll illustrate that not only does this illustrate or help in the community aspect of things, showing compassion, showing awareness and willingness to learn, but it also helps the efficiency of the system as a whole, because it eliminates a lot of the roadblocks that could be slowing down the system. Not only that, but more importantly, it is the fact that it helps with patient safety. Being able to clearly communicate with those communities allows you to get rid of a lot of the risk that comes from poor communication. It will improve compliance within the patient and ultimately improve the healthcare outcomes that were an issue as we were discussing at the beginning. Now, this is looking at it in a local, kind of a smaller picture, and the reason why I wanted to add the next two slides is just to take it one step back and look at the bigger picture, understanding that the changes and the information that we receive at a local, more intimate level does have bigger implications if done correctly, and it can lead to bigger change. Now, ways that the CMS, or Center for Medicare and Medicaid Services, is looking to integrate equity into quality programs includes gathering this data, mainly by creating. Okay, I think things are good. Okay. All right. So a way that the CMS is looking to integrate this equity is by developing a minimum requirement as far as data to be collected through the electronic healthcare records, in order to kind of get a better understanding. Now, through these data collections, a facility can get an equity score. And because we're collecting multiple data points, you're able to stratify that data to better recognize specific areas that would require some sort of quality improvement or some sort of intervention, in order to improve. All of this being done confidentially, of course. And the next slide, just to kind of summarize and really show that this does have a bigger role, not only in terms of the impact that it has in our immediate community and the hospitals, but the fact that seeing how change affects these communities can lead to the proper changes in public health policy that is what's really needed, and this is not the solution to the problem. This is one of the many ways that we can help it and get more data in order to actually treat the issues. And the next slide, I think we have a good little culmination picture of the Skagit regional team, I believe. There we go. It's a good looking squad. Wonderful. Thank you so much. So in summary here, we have the contact information for the members responsible for putting all this together. If you have any questions, feel free to drop it in the chat and we'll be more than happy to answer them. If you have any questions that come up after the presentation, feel free to reach out, email us, call, whichever, and we'll be able to find the information for you. Thank you.
Thank you to Angel, Dr. Mantooth, and Dr. Ceballos. We are so grateful to learn from the work that you guys are doing down at Skagit Regional. I'd also like to give a special thanks to Dana Kearney, who's the co-chair of the Skagit Regional Hospital's DEI committee. Dana joined the planning team this year, and she's been instrumental in deepening our collaboration with Skagit Regional Hospital System. So thank you, Dana. It is now a great pleasure to introduce you all to Devon Nixon, who has been one of the key players in planning this conference the last 2 years. Devon is a family and cardiovascular nurse practitioner at Peace Health, and she's also the nursing program advisor at Western Washington University. She received her Master of Science in Nursing from Gonzaga University and is board certified by the American Academy of Nurse Practitioners. She serves as the VP of the Mount Baker Nurse Practitioners Association. Originally from Capitol Heights, Maryland, her family of origin came to the Pacific Northwest as part of her father's US Navy service. She lives here now with her husband, her kids, and her dogs, and she proudly calls Whatcom County home. Devon, welcome.
Thank you for that introduction. Can y'all hear me okay? I want to talk to you briefly about the North Sound Health Equity Scholarship. I can't stop smiling about this because in 2010, I myself, as a nursing student at Bellingham Technical, applied for a scholarship through the Checknet Health Foundation. And in my statement, I remember writing that my hope, my goal was to come back and practice nursing in this community. So I'm just thrilled to share with you all that part of the work that we do for this conference is the creation of the North Sound Health Equity Scholarship. Last year, we were able to create this scholarship to raise funds and to award nurses, physician assistants, medical students, and nurse practitioner students right here in the North Sound. So throughout the conference, you will see information about the scholarship. You know, when I work with students, when I do this work in the community, one of the things that people say is that they feel overwhelmed, that they want to do something. They've got all this new information and it can be heavy, just like Su Ling had said this morning. Having a call to action is really important in this work because sometimes it can absolutely feel like you're banging your head against a wall. But by giving a little, by sharing with someone that you know might be compelled to donate to the scholarship, we're literally changing the landscape. Listen, I'm a Black woman in Whatcom County. I have to drive to Seattle to get my hair done. If I want a smoked turkey wing, I have to, never mind, they don't sell them out here. I'm saying all this to say, finding a medical provider in my community that looks like me is nearly impossible, but this scholarship helps make that happen. So you're seeing some quotes from some of our scholarship recipients. I have to say, it was just such a pleasure to do this work with the people on the scholarship committee. This was started in, oh gosh, we started it in 2021 and gave awards in 2021. So folks are working hard to make sure that your donations get to students who are studying so that they can come back and provide you care here. I also want to say hello to all my students and colleagues, and shout out to Skagit Regional. I miss you guys. I love you forever, and you do awesome work. I'll be back later on in the conference to talk with you more, but please do drop any questions that you might have about the scholarship in the chat, and we'll continue on with our programming today. Thank you for being here.
Thank you, Devon. This scholarship has been such a wonderful thing to come see from an idea to become reality. And thank you for the words you just shared, kind of highlighting how important it is. I'm now very excited to introduce Dr. Dakota Lane. Dr. Lane is a family medicine physician and the medical director at the Lummi Tribal Clinic. He was born and raised in Washington in Bellingham, and he's an enrolled member of the Lummi tribe. During his childhood, he would help run his grandfather's fireworks stand on the reservation, and he fished with his family for salmon in the Puget Sound. He then went to the University of Washington, where he graduated with a Bachelor of Science in Electrical Engineering. Upon graduation, he decided to switch careers and join the Peace Corps, where he served as a high school teacher in Malawi, Africa. After the Peace Corps, he attended medical school at Weill Cornell Medical College in New York, followed by family medicine residency at the Halifax Health Medical Center. Since then, he's been busy with his roles as physician, medical director, and father of 3. And for the last several years, he has led his community's public health response against COVID-19, including contact tracing, quarantine policies, participating in the Novavax vaccine trial, and rolling out all 3 EUA-approved vaccines. Dr. Lane, thank you for sharing your time with us today. Welcome. We're excited to have you here.
Thank you. Can you guys hear me well? All right, thumbs up. Thanks for that introduction. And without further ado, I'll just jump right into my presentation. Can I get a thumbs up that you can see my screen? Okay, so I was invited today to talk a little bit about the experience of healthcare in Indian country. Many of you probably haven't interacted with many tribal members except for in the setting of an ER or a hospital visit or even outpatient visit. And so I'm here today to talk to you about the tribal experience through the lens of Lummi and what that experience is like. Okay, so unfortunately, you work a long time as a physician and hope someday you do have a conflict of interest. At this point, I don't have one yet, maybe another day. And then just for a picture, I'm sure all of you have this same picture. That's when I got my COVID vaccine, the first shot I got. And that was administered by my cousin, Alyssa Lane there. It was such a joyous day. Okay, objectives, I'll talk a little bit of introduction, of course, jump into a patient story. I am going to talk about Indian healthcare and health services, Indian treaties. You can't really talk about healthcare without the treaty, understanding treaties, a little bit about the Lummi tribe, and then somewhat digress, but definitely related to the opioid epidemic, and then talk about the Lummi healthcare. And there might be some of you from Peace Health. I presented a similar presentation to Peace Health last year. I've added a few slides, but I think it's still relevant, so I hope you learn some more after this. Okay, I think Dr. Gadzik gave a nice presentation. My bio, just want to point out I had the best bowl haircut ever in Malawi, Africa. Even though I was tribal, they still call me white over there. They call me Mzungu. And one other thing I'd like to add is I am a Peace Health community board member since last year. Okay, we'll jump straight into it. I think it's best to view this lens of healthcare through an actual story of a patient of mine. Obviously, I modified the age to protect her healthcare, but you'll get the general story. Patient Jane Doe, an adult woman arrives at the Lummi Tribal Health Clinic to establish care. She seeks me out specifically since I won't be racist towards her. She was currently seen by our psychiatrist, sorry for the misspelling there, Dr. Ben Danielson, who had been assisting her with anxiety medications and recommended the patient to see me. Of course, her first request is Suboxone and clonazepam. And as a primary care provider, those two things, or these types of controlled substances, just kind of raised the blood pressure and anxiety. And she was visibly obtunded. For those non-health professionals, obtunded means just falling asleep while you're talking to her. Naturally, I had a lot of suspicions, but I learned more. She starts break down crying. She tells me about being raped for years as a child by her mother's boyfriend while her mother struggled with addictions. When she came forward about the rape, she became disowned by her family, lived on the streets, eventually, and not surprisingly, struggled with addiction on her own, had 2 children. And why do you think she was obtunded? Her UDS, or urine drug screen, is clean. So we didn't find any other street drugs and other things to suggest why she was obtunded. I learned, and this was after discussion with my psychiatrist, she's had so many nightmares. Literally every single night she will have nightmares of being raped, that in order to prevent those nightmares, those realistic life-altering events, is being repeated every single night, and she's unable to sleep. Just terrible. And it, like, what? I mean, why? What is happening in this? Why is this so common in Indian country? This has made it even all the way up to the federal level, where they've had the Violence Against Women Act, particularly in Indian country. Why does this trauma, so this type of trauma manifest in the form of addiction? And these are all really big questions. I really appreciate the first presentation that really captured it in a data form, all these things that are built up against it. But I think in Indian country, we have some very specific things that led to marginalized people, even within the Lummi community and the Indian community, having this life outcome. So we're going to segue a little bit, and there's no way to get to, at least having an understanding of why that happened without delving into Indian treaties. And I think American history, we've all come to realize, is told through the lens of the conquerors. And I should be clear, my dad is Lummi, my mom is white. So I am very neutral on this because I am very much a product of this history, and I don't really blame anyone for this, other than specific policies that we can change going in the future. So starting with this is, many of you probably do remember from your high school history lessons, the federal government had this manifest destiny. In other words, the constant westward expansion for growth. And it was all done in the name of God, capitalism, and democracy. And you see this nice picture of an angel, obviously representing God. You see these trains coming across and settlers coming across, and then farmers down here in the lower part. And then just off in the little corner here is this dark area with bison, the tribal people being pushed off the land. And that very much was the view back then. And the federal government made a conscious choice that they were they're going to try to avoid all-out war because of the cost of it and the inability to consistently provide security. And so they moved towards developing this policy of treaties, where they treated each Indian tribe as a sovereign nation. So that means sovereign nation like Canada or Mexico. And I want you to remember that. That means when our tribes negotiate today, we don't negotiate with the state. We only negotiate with the federal government, because the state doesn't have the authority to negotiate with sovereign entities. So keep that in mind when you read in Seattle Times about, like, well, why does this tribe get to do that? It's because they're a sovereign nation and recognized and supported by the Supreme Court, because that's exactly the treaty that our federal government got in, how the federal government developed relationships with our tribes. Within those treaties, there's a lot specific to each tribe, but generally they included the rights to traditional hunting fishing grounds. The federal government also agreed to provide for education, healthcare, and well-being of the tribes. And in return for all these wonderful benefits, the tribes agreed to move on to the reservation. In particular, with Lummi, we signed a treaty in 1855. Sorry for the misspelling, it should be Treaty of Point Elliott. They agreed to move on to a then 15,000 acre reservation. Was supposed to be include Nooksack and Samish, but they refused to move to Lummi Reservation. And of course, Nooksack developed their own reservation upstream of the Nooksack. At the time of the signing in 1909, in 1909, census documents only 430 Lummi tribal members living on the reservation. A little bit, so it sounds all nice, right? Yes, we're going to enter into an agreement and we agree you're a sovereign nation and thank you for signing this. And by the way, please move on to this land. Now, naturally, many tribes did not want to move. And the option was move on to this land or the federal army will come and kill your people. So a lot of tribes obviously didn't have guns then. That was very much a weapon of war that was used against tribes. And it was illegal to sell guns to Indian tribes for that very reason. And so you can see that the most well-known thing that was covered in the high school history classes were the Trail of Tears, where the federal government moved all of the Indian tribes of the Southeast to what was then the Indian Territory of Oklahoma. And they all moved there. It wasn't that great. A lot of people died along the way. And I should note that the Seminole tribe in Florida, even though the Seminoles that here in red are pointed as going up this way, the majority actually did not go to the Indian Territory. Many of them, the Seminoles that are in existence today are one of the only unconquered tribes, because what would happen, Florida is thought of as like a paradise today. Back then, we didn't have AC, mosquitoes were terrible, crocodiles were everywhere. And sorry, gators, not crocodiles. Gators were everywhere, and it was just a big swamp. Nobody wanted to live in Florida then. And now, of course, with the advent of modern technology, a lot of people like living there. In addition to moving us off the land, while that was traumatic, probably the most traumatic and debilitating policy was this policy of education, re-education. And the motto of it was famously quoted here by a well-known Army lieutenant, kill the Indian, save the man. And the idea is that they would forcibly remove children from their families and then put them in boarding schools. And most of these boarding schools were of Christian denomination, a lot of Catholic, a lot of Christians. And the idea is that the religion we were practiced was heathens. We were heathens, and they were. You can see in this well-documented picture, you have these children in their traditional regalia, nice long hair, and then switched to Western style clothing, and their hair was cut. This was taken in 1900, and then they were given their names were changed to English names. And while there, of course, there was a lot of emotional, physical, and sexually abusive, or they underwent emotional and physical and sexually abusive torture. And and guess what? Guess what well-known villain studied this same strategy and implemented it? That would be Adolf Hitler. And when I've reviewed this and read the history, there's a few comments that it was believed Adolf Hitler studied the US government's relationship with tribes as a way to exterminate or remove a specific group of people. And he modeled a lot of his policies after this. So the saying that, whatever the United States does, the rest of the world watches, still, was happening way back then and continues to this day. Not necessarily the boarding schools, but both positive and negative policies that we've implemented. In 1978, the Indian Child Welfare Act, 1978, that wasn't that long ago. My dad was born in 1960. And so the Indian Child Welfare Act allowed parents to decline to send their children to school, and they could go to the local school instead of being taken away. And so that wasn't that long ago. The other thing is, so they went to these schools. They went from whatever time they were forcibly taken from the families, went to these schools, and then graduated, and then kicked out. And first thing they're going to do is go home. And after all of this trauma, how do you think they're going to serve as, are they going to be nice, upstanding, civic-minded citizens? Or are they going to be bringing all of this trauma with them back to their community? And here's some more pictures. Canada probably done more than definitely done more than the United States in investigating and research and understanding the full toll. They operated similar residential schools. It's estimated they forcibly removed 150,000 children. And this is not just like some remote thing. There are many of my relatives and lummies who have Canadian relatives. And when this was coming out, I would ask them, and they would tell me stories of how even their parents and grandparents would often canoe from White Rock to Semiahmoo. And I don't know if you've been to Semiahmoo. You go to Semiahmoo, you can just literally look across the bay and see White Rock. They would canoe from White Rock to Semiahmoo to get away from boarding schools, and they would bring their children down because they didn't want to get taken back to the schools. And it's not that far in our own oral history. There was an elder, sorry, I'm getting ahead of myself. At the age of 5, she was playing on the Nooksack River. Whatcom County Sheriff found her, kidnapped her, although he probably didn't believe that, placed her in a residence school. And the crazy thing is that the law was on the sheriff's side. She never spoke of her boarding experience with me other than just that brief sentence I once heard. She ended up coming back to the community in her 50s, was well known within our community, and often spoke of the importance of getting education. She passed away just before the pandemic, but this is like a tragic story. If you recall, it wasn't that long ago, even for, when Trump started, the Trump administration started taking children away from, way back in the border. That wasn't that long ago. And, I suspect this type of children separation will probably happen again at some point. History has a tendency to repeat itself in various forms. I'm not saying it'll be such a big national policy to do this, but the way that our politics go, it's important that we stand up and let people know that this is wrong. Okay, let's switch to just a brief talk about Ling tribe and culture. I think a lot of people don't realize how many tribes are in Washington state. My understanding is about 25 reservations in Washington state, each with their own distinct culture. The Lummi is this tiny peninsula way up in Bellingham. We're the 3rd largest by enrollment in Washington state. We have roughly 5,300 enrolled tribal members. Of those, about 2,800 live in Whatcom County, and the rest are out and about. And so, many of you, like I understand, there's Skagit, there's, Skagit, you guys have a lot of different tribes around your area. Everett does too, has Tulalip near them. And then of course, all the ones in the south. This is our, Lummi has some culturally rich traditions. So this is our late hereditary chief, Chief Bill James. He recently passed away about 1.5 years ago from natural causes, not COVID, thank goodness. This is our former chairman, Chairman Lawrence Solomon. And of course, I grew up here. That's me. I grew up fishing. That's my brother. This is me in the Puget Sound in 2001 catching salmon. This is at Stammish festivals. Like mentioned in my introduction, I grew up selling fireworks. It's probably one of the funnest times in my life. I don't know how I still have all of my fingers. I would often tell my grandpa I didn't want to get paid in money, but just in fireworks. So whatever fireworks were left over, I got to light off. We have the Stamish. This is the canoe what we call them war canoes, which are really skinny canoes. And if you have your balance wrong, you flip over. And then, of course, this is a picture of me and my wife getting married traditionally in 2003. So very much am a product of Lummi and proud of to be part of Lummi. We have amazing food. There's no doubt about it. When the plate is out, when the tide is out, the plate is set is the saying in our family. We get salmon and crab. That's what we ate. I'm going to shift gears to a little bit. That's just to give you an idea about Lummi. And now briefly jump into the Lummi experience with the healthcare system. The federal land policies. So I talked a lot about boarding. I talked a lot about reservations and moving on to reservations, but it didn't end there. The federal land policies, of course, whatever the tribes had, white people wanted. Like it was never satiated their demand. So in 1887, they passed the Dawes Act, where they essentially took whatever reservation land was left and then assigned it to individual tribal members and said, you are now owners of this land. Keep in mind at the time, tribes did not comprehend this idea that you could own land. I know this sounds probably foreign to many of you, but isn't it weird that you can like own a tree? Like, how do you own a tree or own a piece of land when that land was there before you were even born? So how, like, the land is there to provide us, the people who live on it, with subsistence, food. And so this idea of individual ownership is a foreign concept. So in that same act, I think today probably like, oh yeah, well that makes sense. Let's give the land, let's make sure it's assigned appropriately to all the tribal members. But there was a more nefarious purpose, and that was it allowed these same tribal members to sell their land, in other words, parcel off the reservation to non-tribal people. Now this was done nationally, and one of the most well-documented ones was, thought to be related to the development of the FBI. And in Oklahoma, part of the reason why they did this is because the federal government realized that the reservation that they moved everybody to Oklahoma on was full of oil, and the prospectors wanted that oil. It wasn't on non-reservation land. So they assigned it to that land, and then they had all kinds of, like this entire communities would find ways to marry into it or forcibly marry into it so that the white people would get ownership of the land and then sell the oil. So this is something that was very detrimental, and Lummi was no different. So I have a picture of the sign here, Boynton Road out at Lummi. Dr. Boynton was an Indian Health Service doctor way back in, I believe, the 50s or 60s, if I remember right, who didn't feel like he was paid enough and demanded that if the tribal member wanted land, they had to sign over their land in order to receive care. And as well documented, I really appreciate that, the introduction of the data by the first presentation. Bellingham was quite racist then, and there are still racist elements today. And Bellingham, at the time there wasn't much water out here. In the 1970s and 80s, when Dr. Boynton got the land, he then turned around and sold it. As soon as he got it, he converted the land to Whatcom County land, and then turned around and sold it in the public market. And of course, people bought it. And when you buy it, you need water and sewer. And so Bellingham the city of Bellingham paid for water and sewer to come all the way out here and all the way out here to this area and all the way out here to Sandy Point. These are prime properties. And in the process, most Lummis at this time did not have running water or sewer. This is 70s and 80s. not that long ago. And in the process, Bellingham refused to give water and sewer to Lummies. The end result is that Lummies developed their own water and sewer and put it in their own public utilities, and now are serving a lot of community members. But so now I'm still waiting, but the understanding is because of a lot of this allotments, there's a lot of non-tribal members who live out at Lummi. And I want to be clear, if there's some people on here who own land out here, I'm not blaming you. You bought it legally on the market, but the source of the land and ownership certainly is probably not as clean as you think. Let's shift gears a little bit, because I kind of gave you the history of the federal treaties, kind of the Lummi culture, and then kind of the locally how all of these policies went into and affected Lummi today. Let's talk about the opioid crisis. And the reason why I'm going to talk about it is I think, there's no other crisis that affects any community. And it's like if you could design a perfectly designed drug that would not just be a medical problem, it would be a social problem, a criminal justice problem, it's opiates. And that's why I kind of want to talk about this, and because I think it's a byproduct of the trauma that many people have faced. In this case, historical trauma. So let's review this. So federal government forcibly removed Indian children from their families. They provided an education, or a re-education to succeed in the white man's world. Then they sent them home to the reservations after undergoing significant trauma. How successful do you think they would be at contributing to civic society? Let's look at this. Opioid overdose. So this is our internal data, courtesy of my colleague, Dr. Justin Iwasaki, who is running helping to run our opioid response team. You can see that we have a blue bar here, which is our non-fatal overdoses. In other words, they take enough opiates and then overdose. But fortunately, thanks to our Narcan distribution, instead of a fatal overdose, becomes a non-fatal. This was done in July of 2021. We just have been struggling to keep up our data, but nonetheless, it gives you a picture. You can see that in 2018, pre-pandemic, 2018, 2019, we had about 51 or 40 non-fatal overdoses. Unfortunately, we had 8 or 9 deaths. And then the pandemic hit. It's not surprising that we had a spike in non-fatal overdoses. But the amazing thing is, despite these increased overdoses, we actually had a similar level of fatal overdoses. And then this is halfway July of last year. So we're actually on par with 2020. But the surprising thing is that despite all of these overdoses, we didn't have more deaths. And that's really a testament to Dr. Justin Iwasaki and his crisis opioid response team in Narcan distribution, as well as training of the addicts with when to spot overdose and to apply Narcan. That's a whole nother class, but just understand that's happening. So in 2018, Dr. Iwasaki applied for and received a CDC grant to study the opioid crisis at Lummi. And he wanted to create a mental model of opioid use disorders. This is led by Dr. Justin Iwasaki. This is a picture of us when we did our vaccine drive. And some of you may recognize as the Boundary Bay Beer Garden. To the right, you can't see here, is the National Guard. And they were using our vaccines to help, the Lummi vaccines, to help our surrounding community. But one thing that struck me that I really liked was for many of those in MDs and DOs, at least in my school, we were taught that the leading up to a heart attack is a series. He stated, just like a heart attack can be attributed to specific sequences of life events, opioid addiction is no different. So, just like as a heart attack, this individual makes all of these lifestyle choices that lead up to an increased likelihood of heart attacks. The same could be said about opioid addiction. And so to start, he wanted to understand what those life sequences were that led someone to addiction, at least within Lummi. So Lummi, I'm going to digress slightly. Lummi has a sober housing called Schlangen, which is Lummi's language for way of life. So we have, he went and looked at, so the people who go here are people who have recovered from addiction. Either they're sober and on no medications, or sober on Suboxone, and have gotten their families back and are now working, and it's very tightly controlled on who can and cannot live there. And they must agree when they go to that living to strict sobriety. So Dr. Iwasaki identified a few, created this idea. It's called the Journey to Recovery and Wellness Map. And he went to those people who lived in that village and said, all right, here is this thing, and I just need to understand your journey through life and how you recovered. And you have this line here that starts when they're born to today when they ended up in Schlangen village. And above here, you talk about things that helped me get to where I am today and things that made it harder to get to where I am today. And then he just gave it to them and had them write their life story. And some of these are just heartbreaking and also show signs of resilience. So here is someone, and those were the instructions. So here's someone in 1994. They started smoking and drinking. They graduated high school in 1996. They went to inpatient treatment. In 1999, they graduated here. They got the first job in 2002. Had their child in 2003. Had their second child in 2005, started using pills. Then went to jail for the first time in 2006. 2007, CPS was involved. Second time to inpatient treatment, started Suboxone program, went to college. So went to college after Suboxone. Then something must have happened. She said she started drinking after successfully getting off Suboxone. 2012, we moved to Yakima, relapsed. Again, CPS is involved. Started Suboxone the second time around. Got CPS case closed. CPS involved again. Got 2 out of 3 children back. Got a job at the casino. 1 case closed, and has 1 child in CPS. Here's another one. Things that helped me to get to where I am. This individual said sports. At 15 years of age, started drinking and smoking, graduated and started drinking and smoking at 16, graduated in 18. First charged ever for selling weed in high school, started a lifestyle with hard drugs at 19, 20 full-blown opioid addiction, started selling drugs again at 24, busted, had his first child, change of heart, started treatment at 30 years of age. Shoot, I can't read this. Released at 29 from jail, got a job, had second kid by 31. Internal apprenticeship program. There's some more, hang on. Same kind of thing. You see the same story, you know, prison, jail time, pills, heroin, drug court, counselors, Suboxone, all these things helped them. And so some common things that came out of this is the significant level, they all started using young, they all started having children, and the significant level of likely trauma these were experiencing. And for those of you that don't know, we also kept track of the ACE score. ACE is Adverse Childhood Events. If you want to go see what that is, feel free to, while I'm talking, Google ACE calculator. It's only 10 questions. If you go through it, you can even see what your ACE score is. We discovered that those who had an ACE score of 4 or more were 11 times more likely to inject drugs. Getting a score of 4 is not that hard. I would actually encourage you to look at what those questions are while I'm talking, and during their lifetime. And so then Dr. Iwasaki took those same problems and tried to create a model. And this is what he came up with. And I think this is brilliant. I think this, although it's specific to Lummi, I actually think it can be applied to every single individual who experiences some level of adverse childhood events. What you can see here in blue is when substance use is a medical problem. And then in kind of yellow reddish over here is when substance use becomes a community problem. And what we discovered is that adverse childhood experiences lead to some level of unplanned pregnancy or teen drug use, leaving high school, and then all of these activities lead to a drug-related crime. And at that point, it becomes a community problem. And so the drug-related crime, also, they go to jail. At jail, sometimes they're exposed to criminality. And once you're in jail, I think many of us are quite aware that after jail, it's really hard to get a job. And if you can't get a job, then you fall back into criminal activity to fund your substance use. And if you can't get a job, that leads to more family trauma because your children, you can't support your children. You develop housing insecurity, and you need social services, and you need you need social services. What's really nice about this model is you can see different areas that we as health professionals can assist, and that's really early screenings. And then also we as a society can do to help improve the outcome of this. We can have less restrictive employment criteria so that they can get a job. We can, of course, I heard talking about housing insecurity and things like that. We all know housing is a big issue for nationally, but housing policies should focus on making it easier for them to get housing. If you remove all of this, you're just essentially telling these people that they're on their own and making it more likely that they're going to use again. And so, yes, I'm getting ahead of myself. So adverse childhood events. Okay. How much, can I just do a time check? How much time do I have left?
We're running about 10 minutes late. So let's say go to 10:50.
Okay, I will speed through this. I'm sorry. So brief history of Indian healthcare. Thank you. Indian healthcare services. We, in 1921, the Snyder Act allowed for funding of Indian healthcare. In 1954, the Transfer Act, which allowed the creation of the Indian Health Services. 1975, Indian Self-Determination and Education Assistance Act allowed the tribal governments to do self-governance and control federal funds designated for social, legal, and health services. In other words, instead of the federal government administering it, the federal government just gave tribal governments money, and then tribal governments did it themselves. In 1976, the Indian Healthcare Improvement Act, which was a policy by the US Congress to bring the health status of American Indians to the same level as the US general population. And so real briefly, there's a difference. Many of you have heard the IHS, Indian Health Service, and self-governance tribe. So IHS is a federally run health service. And you can see, I took a nice picture from their website. In orange here are all of the IHS health services. What's not listed here is self-governance tribes. So in 1994, the first of 14 tribes opted to receive the federal dollars allocated to them rather than allow IHS to manage the healthcare dollars. Lummi was part of this group of tribes that requested to become a self-governance tribe. So as part of my budget, I receive a federal government allotment to my healthcare service, and then I help manage it. But that sounds all fine and dandy, but the federal government has never actually kept up with, never actually fully funded the healthcare needs. In 2003, you can see Medicare was about $6,000 per Medicare beneficiary. If you go all the way down to the lowest paid federal support, this IHS was about $1,900, which is half of what the federal government was doing to cover for the health of prisoners. And we all know prisoners also do not receive the best health care. So as an example, the Lummi Tribal Health Clinic as a self-governance tribe had 4,800 active patients at this rate would be about $9 million. That's actually not enough. That would be enough to administer to our community, but also that includes referrals to specialists, MRIs, CTs, all those things that our clinic is unable to provide we had to pay for. And, you know, I'm sure you've had many who do not have insurance and have to pay those rates, and it's like exceedingly impossible. So this money would actually run out after 6 months for our community. And fast forward to 2010, the permanent authorization of the Indian Healthcare Improvement Act. This was under the Affordable Care Act that Obama signed. It recognized that to help cover the difference and provide more funding to tribes, it allowed tribes to utilize Medicaid and Medicare and bill them, third-party billing. And so that was, so we get this allotment from Indian Health Service, and then they allowed us to bill it. But even still, despite that, this fast forward to 2015, so 7 years ago, you can see that Medicare, the average expenditure is $12,000. For IHS is about $3,000. So it's still not keeping up with the cost needed. Real quick about our clinic, thanks to our ability to receive those federal funds and then also bill third-party insurances, we are able to offer a pretty broad range of services. We have psychiatry, pediatrics, family medicine, internal medicine, physical therapy, behavioral health, Suboxone, and public health. We strive for an integrated care model, try to meet patients where they are. We have a school-based health clinic that's an extension of our clinic to the Lummi Nation School. There we offer medical and dental systems. We also, medical and dental services. We have also behavioral health there. We also do home visits to frail elders, and we, of course, do walk-in care. All right, so historical trauma affects tribal communities today. The federal policies really set the stage, and I really like the beginning opening presentation, because it's very clear that these federal policies and policies that were set up by local and state governments really encouraged and led to a lot of these downstream effects, unintended consequences, or some of them intended. Residential schools played a huge role in negatively impacting Indian country. And Lummis in particular, and likely a lot of other tribes, remember that as part of their healthcare, we had to give up our land from Dr. Boynton, and that actually skews their view of healthcare outside of Lummi. I can't really highlight the importance of ACE, the adverse childhood events. It's such an important measure of the level of trauma that a patient experiences. And of course, all of these combine to set the stage for addiction. I know we have a lot of healthcare providers here. I would, one of the things when you see, I think about how many of you interact and see tribal patients. It's usually in the setting of what I just described in the very beginning. It's a patient who looks obtunded, clearly had a hard life, and is coming to ask for Subutex and a benzo. I'm a doctor, and I'm like, oh man, I don't want to do this, But when I actually, kind of suppressed that initial reaction and just sat and listened and learned from her, and then also got confirmation her UDS was clean, it became clear that she was speaking the truth, and I couldn't find any reason not to believe her. I say sit down and speak with patients. The reason why I say this is there's some cultural, I guess, faux pas that occurs between providers and a lot of tribes. And the best example I can give is, to this day, the conversation I have with my dad. Every time I call him up, I go, hey, Dad, how's it going? And then just when I'm like about to say, are you there, Dad? He'll say, good. And they don't need, we in Western society are trained, if there's a pause in a conversation, we got to take it. We got to jump in and establish our dominance. And that's how a lot of us are. I mean, think about all those who went through med school and residency, right? You got to speak up, and if you pause, it's a sign of you don't know what you're talking about. That's not the case with our patients. And so, think about your interaction. You walk in the ER or health, hospital, and you have 15 minutes to see them, and you're like, this is the problem. Do you have any issues? And they just give you what looks like a blank stare, but really they're trying to process all the things they're using, the language you're using. And if you're and as a community, we've been trained, if we speak up too much, then people respond in ways that just ignore you. So I encourage you to sit. If you sit down and look them in the eye, give them the time to speak, you'll learn a lot. Think of the mental health model of addiction that I showed you. For government policies moving forward, I firmly believe some level of decriminalization of drugs, not selling drugs. If you're selling drugs, you should be arrested. There should be a more harm reduction focus. I think we need to really rethink good, like the ability of good paying jobs and who has access to those good paying jobs. Of course, affordable housing. And I will just leave it at this. It is now 10:49. I don't know if we have enough time for questions, so I'll turn it over to Erica.
Let's give just a quick minute for questions. Is there anyone who has a burning question for Dr. Lane? If you can put that in the chat, we'll give that just a moment. In the meantime, I just want to say thank you, Dr. Lane, for that presentation. It's such an important reminder that in order to promote health equity for our tribal patients, we need to understand the roots of the barriers to their health and the historical factors, the generational trauma, the childhood trauma, the medical mistrust. And without understanding these roots, we can't address those barriers and advocate for better quality of health and quality of life for our patients. I'm just looking now to see anything in the chat so far. Lots of thank yous to Dr. Lane. I appreciate in your last slide how you mentioned government policies as well. I think that oftentimes as a medical provider, you think that your choices for the day, what you can impact, are all within the conversation between you and the patient in front of you. And that's a huge part of it. But also as a medical provider, as a medical team member, your voice carries weight. And so one of the things I ask of everyone attending today is to say, how can I use that privilege? How can I use that voice to be advocating for some of these policies that I know will address really essential needs and reduce some of these barriers that our patients are facing? Checking the chat once more. Sasha says, thank you for understanding that it's deeper than just what's on the surface. So true. All right, well, let's move forward then. At this point, I am excited to introduce Dr. Glenn Garrow. Dr. Garrow is a board certified internal medicine physician who has been with Peace Health for the last 6 years and has been practicing medicine for almost 20 years. He is originally from Oahu, Hawaii, and he attended the University of Hawaii John Burns School of Medicine and then trained at the Providence St. Vincent Medical Center in Portland. He will be introducing the Providers of Color Affinity Group. Welcome, Dr. Garrow. We're excited to have you here.
Good morning. Thank you. Can everyone hear me? Great. Yeah, so I'm the inaugural president of the Providers of Color Affinity Group in communities for Whatcom, Skadden, and Island counties. And the program was started a couple of years ago by myself and Dr. Koyamatsu, who's also here. And I was asked to discuss the importance of the North Sound Health Equity Scholarship and how it's important to provide more providers of color to all communities, including ours. And this scholarship is definitely a blessing to enhance more providers of color, especially as medicine is underrepresented by minorities. And oftentimes we are financially disadvantaged as we endeavor into the field of medicine. And this scholarship will enhance the ability for minorities to follow their dreams by lessening the financial burden that comes with going into medicine. As a Filipino-American physician born and raised in Hawaii, I was not fortunate to have a scholarship. but I benefited from the University of Hawaii's post-baccalaureate program called Imiho'ola, which in Hawaiian means those who seek to heal. And after my undergraduate studies, I spent a year doing this program. And it was intended to allow more underrepresented students to go into the communities and practice medicine, especially for communities that are similar to someone's background. And in my class, there were people of Filipino, Vietnamese, Guamanian, Samoan, and Hawaiian heritage. And all of these groups are definitely underrepresented in medicine, not only in Hawaii, but the entire United States overall. And one of the great things about this program is we were benefited with a monthly stipend during this one-year program. So it was similar to a scholarship, and it definitely allowed us to, pay our bills and, live while we're going to school that 1 year. And so I personally want to thank all the donors who have contributed to this scholarship fund. It's a tremendous help to a lot of the students that really want to go into medicine and not want to have the financial issues as a burden or as a way of not going into medicine. And so thank you for your donations. And I ask that, all of us and others really contribute to this. It's going to help a lot of our students, definitely. And also I want to say thank you to all those that have worked tirelessly to put on this conference so that we can, ensure that people know about the scholarship and what we're trying to do for, providers of color in this community. Mahalo and salamat, both meaning thank you in Hawaiian and Filipino languages. Thank you very much for having me.
All right, Dr. Garrow, thank you for sharing some of your personal story and for highlighting the scholarship. Again, looks like Rachel just posted an update to the chat. It looks like we're at about $1,200 so far for this morning. The link is there, and we would really encourage you all to support our BIPOC medical trainees in our community. All this money goes straight to those students. At this point, I am excited to welcome back Devon. Our next segment features a collaboration between Monica Kohler and Devon Nixon. Monica is the founder of Connecting Community LLC, an organization which creates opportunities for connection and a shared sense of belonging through digital storytelling workshops. I'd like to give a special thanks to Monica for her partnership in this segment and to Devon for leading this conversation. Welcome back, Devon.
Hi again, everyone. We are going to be hearing from patients in our community about some of their experiences with the healthcare system. But before we go into that, I just want to share a couple of things. In recent years, it's become customary, especially in our part of the nation, to start events with a land acknowledgement. And more recently, an unpaid labor acknowledgement. I've had to sit with those and ask myself, why do they feel a little bit off sometimes? And after sitting with that, what I realized was that the land was what they were after. The unpaid labor was another thing that was desired. I want to take a moment to acknowledge the people, a lineage acknowledgement, if you will. To our Indigenous and enslaved ancestors who did not survive Indigenous genocide and the Middle Passage. To those who did and endured the horrors of American chattel slavery, were forced onto reservations and to boarding schools. To our ancestors in unmarked graves with no opportunities for self-actualization. To our grandparents who cannot bear to talk about their intimate knowledge of domestic terror and state-sanctioned violence without tears welling up in their eyes. To us, to your children who silently endure so much lest we be called sensitive or told we have a victim mindset. To our children for whom we are so desperately trying to ensure won't need their own movement to tell the truth about our history and dismantle systems that have been put in place to keep us in ours. We hope our kids can carry this work forward. And most importantly, to our patients, we do this work with you in mind. So with dehumanization, which is a prerequisite for all of these things that we're learning about, it begins with dehumanization of self. Dehumanization is a two-edged sword. It goes in both directions, and we've all suffered tremendous spiritual injury simply by being born into a racist culture. While our suffering looks very different, we all have suffered and we're all injured. You know, I was walking on the campus of Peace Health years ago as a student, and I was walking with a white nurse colleague, and there was a totem pole kind of set back on the trail on the walk behind the hospital to the parking lot behind HEX, which some of you may be familiar with. And I asked my colleague, can we just stop here for a second? Can we just take a minute? And her words were really shocking to me. She said, I don't need to be made to feel bad. She didn't want to feel bad. And stopping at the totem pole to just acknowledge where we are, how all of these buildings and this whole healthcare system is built on Coast Salish lands would make someone feel bad. But what I take away from that is that maybe she didn't want to feel. We're supposed to feel. We're supposed to feel. We should be allowed to feel. Feeling is an important way of knowing that we don't engage with as often as maybe we could in academia and in medicine. We can be really intellectual. In fact, I've been working on a framework that I call Health Immemorial that compares and contrasts our modern healthcare system and our ways of knowing and our health promoting behaviors of ancients. Whatever did we do before Western medicine? In that model, the themes that came up during our workshop for the videos that we're going to view together were very similar to a lot of what I've noticed in my work and in my practice. In modern healthcare, we focus on things like working out, restrictive diets, individualism. I want to do as much as I can for myself, by myself, for as long as is humanly possible, right? Intellectualism. Everything's got to be evidence-based, evidence-informed. Ask yourselves who participates in the evidence, who gets to say where the money to do research goes, and who participates in that research. But in a health immemorial model, we focus more on movement, nourishment, love or community, and worship or awe. And these are health promoting behaviors that Indigenous people all over the world practice as a way of being. You know, these themes definitely came up in the work that Monica of Connecting Community, myself, and the other storytellers, as we met and we talked about our experience, we provided healing space for one another to be able to tell these stories. it's not easy to tell a story of something that impacts you greatly every day. It's not easy to share a story about something that haunts you decades later. And so, well, I give a trigger warning because yes, there's talk of loss of pregnancy. There's talk of racism and violence. There is talk of all of these things that, while triggering, are also true. And it's okay for us to feel with one another. Yes, addictions, there's talk of addiction, families being separated, a lot of the things echoing Dr. Lane's talk you'll hear in these vignettes. But I invite you all to feel with us, and I invite you to feel for yourself. Embodiment is a way of knowing. We feel things in our body before our brain has a chance to process and make meaning of things. So I invite you into your own body to feel with us as we share these stories. Thank you to all the storytellers, to everyone who participated, the tears, the space we held for each other, the work that we've done. It's just the beginning. So keep your eyes and ears open as we do conferences in the future. There will be calls where you all can share your stories. But for today, we're going to share stories of health and memorial, stories of personal experiences, stories of holistic wellness, and what it means to us to be healthy, who we are, where we're from, and what health means to us. Again, trigger warning. And I just want to remind you all that this portion of the conference will not be recorded and sent out in your link. These stories are personal. Thank you for being with us. And I'm going to hand off to Eric.
You know, this is the third time that I've watched these videos, and every time I feel the need to take a step back and sit and just breathe. And I am so appreciative to Monica, to Devon, to the other individuals who put their time and heart and energy and vulnerability into these videos, for being willing to share their stories with all of us today. These stories so clearly highlight to me why we are here today. We are here because we want the best for every single one of our patients. We are here because our neighbors and our colleagues and our community members deserve to feel safe and free in our community, in our parks, in our streets, and especially in our clinics and hospitals. I want to give us some time now to take a break, to process, grab some food, coffee, tea, whatever it is you need.
Hey everyone, welcome back. We were having a really exciting discussion in our group and we ended suddenly, but look forward to continuing these discussions later. But for everyone coming back in, we're just welcoming you back from our breakout groups. My name's Ariel Furtado. I'm a nurse practitioner at North Sound Family Medicine in Bellingham, and I'm on the planning committee. And it is my pleasure today to share with you a little bit. So joining us next today is Dr. Danielson. He's our keynote speaker. But before we move on and hear from Dr. Danielson, I just wanted to briefly highlight some work that is being done in our community by something called Vamos Outdoor Project. They're a nonprofit that's working to connect families to environmental education opportunities, and they partner with a lot of organizations locally. They primarily work with the Latinx and English language learner communities, and they work to eliminate barriers that make to access that make it harder for Latinx and English language learner students to access recreational environmental education activities. Something I think that's really cool that Vamos does is they, hold on, let me figure out how to forward my slides here. They provide things like transportation and food and the equipment that kids need to engage in activities and also supervision. All the programming is free, and they have scholarships for their students. And I just know some of the people that are involved in this work, and they do incredible work. They knock on doors of families. They make sure that language is never a barrier.
All right, next. It is now my great pleasure to introduce our keynote speaker, Dr. Ben Danielson. Dr. Ben Danielson is a clinical professor of pediatrics at the University of Washington. He graduated with a Bachelor of Arts and Bachelor of Science in Ethology from Harvard University, attended the UW School of Medicine, and completed his pediatric residency at Seattle Children's Hospital. He's been well known and beloved for his many years of community work, and he has championed efforts to increase access to healthcare and to fight racial health inequities. He's been a tireless advocate for children and their families, as well as for recruiting and retaining more persons of color into the healthcare workforce and supporting academic institutions. Dr. Danielson was the longtime medical director of Odessa Brown Children's Clinic in Seattle until late 2020, when he resigned, citing institutional racism and a lack of change in the organization. He's recently been appointed as the director of the newly established Allies and Healthier Systems for Health and Abundance in Youth Center in Seattle, which seeks to end youth incarceration in Washington State by 2030. He's currently the chair of the Governor's Interagency Council on Health Disparities and has served on a number of other boards, including the Seattle Foundation and the Washington State Health Benefit Exchange. And if that wasn't enough, Dr. Danielson has been widely recognized with multiple awards, including King County's First Citizen Award in the summer of 2021. I have one more really exciting thing I would like to share about Dr. Danielson. We'd like to express a sincere thank you to him. Upon hearing about this conference and the North Sound Health Equity Scholarship, he gifted the entirety of his keynote speaking fee to the scholarship fund. We're delighted to announce that nearly $10,000 in additional funds are being dedicated today to the scholarship because of his generosity. Thank you, Dr. Danielson, for all of your work over the years, for making this possible today. You inspire us. With that, I'll turn it over to you.
Wow, thanks so much. I am so honored to be part of this group and part of this discussion today. Keynote does not sound like the right word, because I think everyone before has been sort of key to this this conversation about equity and this work and this movement. And so I don't know, maybe I'm the low keynote, but I'm really happy to have listened and joined and learned so much. And I can't help sharing a couple of reflections from someone who feels like a visitor to a space that is sacred in its work around equity, because I see so much work going on in your communities to make sure that everyone is seen, to make sure that stories are known and understood. And I find that such an amazing, amazing body of work. There's so many brilliant people doing such great work. A sliver of them part of this speaking coterie today, but also so many more. I know behind each and every one of them doing incredible work as well. It's really, really wonderful. I see you all and I notice these things, and I will share these things with other communities that I know of because you're doing really wonderful things. I so appreciate the organizers and the planners who put so much work into this, and the other speakers. I just, there are thoughts and things that I hope you'll all be taking away with you and streaming in your heads around really what it means to have a, I don't know, a lineage acknowledgement in the way we think about understanding the spaces and places that we occupy. That Devon's comments about health immemorial models, I just hold those so strongly to be educated by our local legislator, local government representative about the history of racism on a local level, and the stories behind that is just so incredibly powerful. There's a rhythm in all of this, and I keep seeing this rhythm of systemic and personal and systemic and personal that come through in the sessions and the pieces that I've been able to hear, and it feels powerful to me. I'm going to be, I don't know, ruminating on that for a long time. Systemic and personal and systemic. I wanted to share a few minutes of talking with you, but I'm not sure that my yammering on is always the most favorite thing somebody wants to experience. So I'm backing it up with mural art, because I've just become a real fan of mural art these days, and I think they tell stories and express things so much more beautifully than any one set of words alone. So if I bore you, at least you'll have something nice to look at during the time that we're talking. And with that, I'm happy to sort of start into this. I was thinking a lot about mural art, and so I couldn't help but look at the examples of arts that are in the communities around you in the North Sound and Bellingham and Whatcom County and spaces like that. And you have a wonderful, beautiful day walking tours to take, I think, through your community spaces that you have amazing art to share and consider and talk about. You have places where art just shows up where you least expect it. And I think this this journey, this equity journey, whatever that means, is about discovering the things that aren't usually seen, aren't as easily observed and known. Where we are in this equity journey is something that you've been talking about all day today, and understanding and sharing and having conversations about. And I think that what's important about this is that those conversations continue. What you've been talking about so incredibly has been this multi-layered history of your communities and the spaces you've been in, the work you've done to lift up issues of equity and racism, the counter work that's happened, the way your murals have sometimes been defaced by folks who do not follow the path of anti-racism, who do not agree about the importance of equity. A history that goes back so many hundreds of years, hearing those things today about the KKK being the largest KKK sector in the state, maybe in the region, the many different stories and histories of covenants and of displacement and of the way spaces and places are named. The Picket Bridge as just one example of many spaces in our Northwest where it was a general from the Confederate Army getting named for a bridge in your community. And you know this, but Highway 99 is named after the Confederate vice president for the longest time in this state. I feel a little bit connected to your spaces because I was also reading about different stories, like the story of one of your great educators at Western Washington University, a professor named Eunice Faber, I want to say, who also grew up in DC like I did and experienced that sort of living in a diverse multicultural space in DC, then came out to Seattle and to the Central District where I worked for the longest time and where I still live. And then came to Western Washington University and then had to fight and be fierce because she was facing extreme discrimination and she had to stand up for for her rights as a woman, as a Black woman, as a extremely talented teacher and educator. The stories that we have are linked together, aren't they? We have experiences that kind of bring us together, interweave us, bring us apart sometimes, and help us find ways to get back together again. And the story of your region is just powerful and personal and systemic and personal. I just can't help reminding myself of that in such a powerful way. We go through these spaces and we try to talk about issues of racism, and sometimes there's devolving conversations that sound a little bit too analytic and academic or something about what structural racism really means and is. And I've never found a better or quicker definition of structural and systemic racism than this line from Ta-Nehisi Coates that says, "Race is the child of races, so not the father." In other words, that our country created racism well before we were a country, and then have used race in order to justify, structuralize, and implement racism over time. And it makes you think differently about the way you do your work. So maybe we don't talk anymore about differences in health outcomes based on race, because race is just a construct. It's not a biologic thing, really, to any extent. Maybe we talk about differences in healthcare based on racism instead. Once your language starts to change, then your actions hopefully do as well. But understanding that and moving from that is just so important, so much of a reminder to me about how we do our work, because this work is significant, and what you're working against is so terribly powerful. As you saw earlier today in one of the earlier presenters talking about the systematic process of erasure and how that impacts for generations and generations and generations, that process of stealing a language and a culture and an identity and everything that makes you you, how extremely damaging that layer upon layer of trauma is. That's not something you're going to measure in a bar or a graph, although I know we'll all try to in our health intentions ways. But it is something that will continue to have deep impacts, and without really all-out efforts from us in a shared and powerful way, we will not be seeing a difference in these things. We'll only be seeing incremental changes. The impact of erasure, the horrible Holocaust of racism continues to visit us and continues to have impacts across our spaces. I love, in a way, that when I looked at your Bellingham proclamation of resolution about racism being a public health crisis, that in your whereases and wherefores, you named these things. You named that Black mothers in the US die at 3 to 4 times the rate of white mothers, and that was a tenet for your proclamation. You're bringing this idea of local government, local foundations working together, healthcare people working together, understanding history, understanding bigger systemic stories within the space of your resolutions. I hope you've all read that proclamation that was ratified, September of last year, after a year of work, because I think it's really, really important language in so many ways. And it tells this deeper story, right? As a pediatrician, the space and understanding I know is that if you're Black or brown in this country and you have abdominal pain and you go to the ER, you're 80% less likely to get treated for your pain. And that's regardless almost of the ER, the best intended ERs, the best caring people in ERs. This is the nature of systemic racism. If that same pain means you need an imaging study, if you're Black or brown, if you're Hispanic in this country, you have lower odds of getting the imaging study that might diagnose that appendicitis or that surgical abdomen that might be requiring care. That's across ERs, across this country, across our spaces. If you need surgery and you have surgery or are in the hospital, if you're Black or brown, the chance of you dying in the 30 days after that surgery, if you're a child, is 3.4 times higher. This is the nature and the reality of systemic racism, and racism in our healthcare system specifically, because we have to be talking about this as the loss of lives, of the loss of productivity, of possibility, of hope, of dream, of power, of identity. These are lives that we are talking about. This is something you kept reminding me of in all of your discussions today, which is so important. And it's also important for us not to fall into the trap of thinking that perhaps racism in healthcare is getting better, because it isn't. If you're a Black woman, you're still twice as likely to die of breast cancer than a white woman today, just like it was 20 years ago and 30 years ago and 40 years ago. If you get a liver transplant, you're still less likely to survive that transplant based on what people see of the melanin in your skin. I should have started my talk with this by saying that I'm a light-skinned black man with a white sweater over a blue shirt, sitting in a room with a beautiful blue piece of artwork behind me. And in this space, that visual description is also a description that will be carried into every space that I walk into, will be analyzed, and will impact the way my health outcomes are likely to occur. This is so true across the age span. And the only place actually where you get more care for having more brown skin is when you should not get more care at the end of life, say when you have terminal cancer. And quality of life should be the stronger component than intensity of care. That's the only time that having brown skin makes you more likely to get more care, which of course is not what you want, which is not beneficial to you. This pathway of healthcare throughout the lifespan, as we've talked about, is something that we should be understanding with such deep, solemn regard. And we have to pay more attention to what we're talking about today in terms of racism, because of the overall impacts and the overlying impacts of intensification that have been happening in the last couple of years. And we know this in BIPOC communities and Black, Indigenous communities. We know the risks, the added risks that these days have been adding to us. The Navajo Nation knows what has happened when outside people have introduced infectious agents into their spaces and places. And we know how life-threatening this time in particular has been. I am so tired of the stories of death and loss, of the loss of life, of the harm that this time has been really visiting upon the communities that I love and care about. We know how this works in our societies and our communities. And we know that it is changing life expectancy even as we sit in this space and time. If you looked at the change even in the first year of the pandemic, it did not visit different communities in equal ways. If you're Black, you lost 3.25 years of life expectancy in the first year of this pandemic. If you are Hispanic, Latino, Latinx, lost nearly 4 years of life expectancy in the first year of this pandemic. This is racism. This is the impact of racism amplified by the acuteness of a pandemic on our lives. This is significant and tragic and worthy of note. And it's not something that is unseen or unnoticed in healthcare. The most observant of our healthcare system are nurses who see it all and understand it all and connect it all. They know that 2/3 of the nurses surveyed in this study from just a month ago say they've personally experienced an act of racism in the workplace. And despite trying to change it, they often find that they don't have support in their leadership or organizational structure to make something happen and better. We know that it is pervasive and that we see it every day in our spaces and places of work. And we also understand perhaps that our healthcare system isn't really ready to address and truly, honestly contend with issues of racism. Just look to this experience of this chief resident from St. Louis who was writing articles about racism and submitting them to journals, only to have the journals change the title because they were not comfortable with the word racism in it. And the more he brought up this issue, spoke out about it, the more he was cautioned that he would be seen as an angry Black man if he spoke too much about it, and people would distance themselves from it. Our healthcare system is not ready to fully talk about this, not in the way that you've been talking about this today. And I think you just need to realize that and understand that, because the deeply woven systematic issues are so hard to unroof if we can't really talk about them. And when we do talk about them, we have to understand them at their deepest levels. Just look at this example of just the way we talk about patients in our healthcare system, our electronic health records. This study that was just out from about a month and a half ago, talking about how much more often, if your skin is brown or Black, you have at least one negative descriptor in the history and physical notes in your chart. The disparaging language of disbelief about your illness, of discrediting your perspective, your concerns, your symptoms, how it's deeply woven into our systems of healthcare, and how much we need to really be examining and understanding that. Because for now, if you're Black, if you're Indigenous, if you're a person of color, if you're Latinx, if you're from the Pacific Islander Rim, if you're oppressed and displaced, you also walk into oppression and displacement when you walk into the healthcare systems. where you're watched more and judged more, where you are criticized more for either being too quiet or too loud. The word stoic shows up so often in the electronic health records of Indigenous people, and it's used as a critique of a lack of connectedness or engagement or emotion at a time when a white person might expect a different kind of expression. These are not just subtle issues. These change care and change lives and impact the way we see each other and see ourselves. And it's not just the families who are coming in for care who have this experience of being watched and judged in the healthcare system, but it's us too. It's us who are working in the healthcare system who enter into these spaces with a sense of who we are, but also with an understanding and awareness, unfortunately, of how we are judged and seen and observed. And that is an exhausting and draining path to be following every single day. Those things have to change, and we have to talk about how change really happens and how change symbolically happens. Because right now, there's a lot of enthusiasm for creating offices and titles with equity in them, but sometimes those titles are pretty empty. This example of a chief diversity officer who was supposed to be hired to a hospital, who the hospital rescinded their offer to them right before they were supposed to start their first day of work because this chief diversity officer seemed to be too concerned about issues of racism. This kind of emptiness of gesture has to be the kind of thing that we at every level of work and inside and outside healthcare have to be paying more attention to, because equity, just like anything else, can be a really good weapon to make sure that equity never happens. We can use equity as a tool to delay, defray, deform, or in other ways make sure that equity in its truest sense just does not occur. And these issues are important because they refer back to the deeper experiences that we all have in our lives, inside and outside the healthcare system, where, as you've heard and know, your health is so much more determined by than anything that's inside healthcare. Understanding what's outside is so important, and acknowledging it and seeing it for what it is. And when you see it for what it is, you know that socioeconomic deprivation is a condition that impacts communities of color in ways that are guaranteeing that the opportunity for wellness is further deprived. When you look at, just for example, the ability to accumulate family wealth, to send a young person to college and afford it, to be able to pass on some wealth to the next generation, to be able to buy a home. Black wealth in this country has not changed at all in this measurement or in time before that. And it is by design. It is by specific and intentional design and by actions that have made sure that that line never changes, never grows, never increases, and never offers the chance of wellness based on the resources that you need in order to have the opportunities for wellness. These factors are important, and the intersections of them are really important for us to understand. And so I'm glad that there have been conversations in small groups that really take into the account the idea of environmental racism and what that means as an experience, and what that means is described by Benjamin Chavez now 40 years ago. Policymaking, enforcement, targeting, and sanctioning, and as well as exclusion of BIPOC communities in order to assure that their voice is not heard in the conversations about environmental justice, and also that we remain the most at risk for the harms of environmental injustice as well. These are the harms that we walk into every day in the space of our work, in the space of our interactions with each other, in the space of the air that we breathe, and that air and the effects of that in our lives, not just in our lungs, but in our lives and expressions, is just something we have to contend with, we have to talk about, we have to understand, we have to become better warriors for, we have to be fierce, because the intersectionality of environmental harm and racial harm is overlapping in such intense ways that we are losing our wellness over it. It is hard to do this work, to do this fight, to be in a space where we're standing up and championing issues of equity. There are so many intersectional issues that we have to be walking and speaking and talking together on. It is hard work, and it is not easy work. There are not any easy solutions. There's not just a simple button that you can press to say we're going to be ending racism and be anti-racist from here on out. We can't just say don't do it anymore. This example from the jurisprudence world was just so chilling and telling to me about when judges purposely instruct jurors to ignore racial cues, the likelihood of relying on implicit racial association actually increases. Just saying don't be racist, not only does it not work, it may actually work in the opposite direction. This is deeper and more complicated than that because it heads into the spaces of everything from our educational system, which is now under attack for even talking about race theory and the impact and interaction of race in our society from time immemorial as well. It's in every piece of our abilities, our rights as people in this system, and so woven into the threats to voting rights that are as active today as they were in the height of the Jim Crow era, is woven into every piece of understanding who we are. It's woven into the way we approach data, because still and today, despite as many efforts as we have, data becomes the best way to erase people. Data is the best way to not see those whose suffering may be the greatest. The issue of missing and murdered Indigenous women is just one example, but one of the most important examples that we need to understand today about the risks of data in its current form and the need for data to be owned by the communities most impacted by the harm that data reveals and does not reveal. And when we see harm, we need to be able to understand how to undo it. I won't go into this for now because it's a longer conversation, but that when we see harm, when we see societal wrong, when we know we're doing wrong, like wrong things to young people who in ways that does not understand that the brains are developing, that social identity is growing, that the ability to be functioning and decision-making and part of a society that is not only one that has been filled with trauma, but one that also opens opportunity in the future. We cannot be locking away those young minds. We cannot be imprisoning some of our greatest resources. It is unjust in our system of modern enslavement that we start from the very early ages and funnel and push Black and brown young people towards prison and then keep them there. These are the things that we need to change. And it's not that we're just trying to make some tweaks or put some grease on a machine or find a little cog that's a little bit broken. These are not broken systems. You know this. These are systems that are working exactly as they are designed, which means, again, that if we're talking about solutions, then they're not going to be small scale solutions. They're not going to be working around the edges. There's not going to be a little bit of polish or grease here or there. These are big changes that need to happen. And I know it becomes hard because we've created systems of work, I think in healthcare, but maybe in other parts of our work and living environments also that are hectic and busy and fast. And I can't help wondering if that's not also part of the design. The more harried and busy you are, the less time you have to attend to the issue maybe of even listening, of sitting back, of understanding, of taking the extra time to know somebody who doesn't look or talk or act or feel or see the same way that you see. This issue of time, the tyranny of time is weaponized in healthcare especially. And I think it is a weapon of racism in order to make sure that we do not gain ground in the work that takes the kind of time that we need to. This is important because, especially right now, I think we're in a time of also great weariness from the incredible number of things that have been asked of all of us, regardless of our spot in society. That weariness makes you sometimes want to think that you don't have the energy of the heart or the space to access some issues that are of great social justice import. And I just want to really remind us that maybe when we're at our tiredest, it's when we most need to be most connected to the things that are most important. I think that's what I kept hearing in some of the talk today, that this is when meaning is really actually meaningful and where our connection to this work becomes the most important it ever will be. It's hard because our system tells us that things are not going well in the healthcare system, despite actually some improving sense of engagement for healthcare workers in general. There's also a significant chunk of people that would say, when they look at our system, that's on the verge of collapse. And that's not just healthcare. I think there's a lot of social and economic systems, government systems, for which people might be saying some of the same things. And so that's the time when we start to need to question where we can make change. And I think that it's a time for us to break ourselves free from the idea that we are not change makers, that we are not able to make things happen. The worst crime for us to do in this time on this equity journey, to me, is to talk ourselves out of our individual power, to talk ourselves out of our combined group power, to say that all of this energy that you've heard today, everything that you've heard today, all of that's been brought forth, that is beautiful and powerful and iterative and creative and innovative and brilliant, that all of that is change in the waiting. That is the kind of power and energy that cannot be denied. And we have to see ourselves as powerful. Otherwise, someone else is going to be really willing to tell us that we are not powerful. This is important. And it's important to get back to the basics as we talk about this, because even as you talk about a time of the impacts of a pandemic of viral proportions, the solutions, when you really look at them, are the kinds of solutions that should be happening that are of importance for societies, for communities. Community level, transgenerational, interventional strategies are actually the things that help us get through times, even times like this time of COVID-19. And this is an important realization. The social structural supports, guaranteed income, guaranteed quality education, the opportunity to know that that your culture and your identity are lifted up. Those are the things that are solutions even to these specific health issues that we might be facing today. When we start to utilize a public health perspective in the work, which is partly why I think the proclamation that you and other communities have put out around racism as a public health crisis, it's named that way, I hope, because public health is also part of the solution, understanding complexity of our individual experience, that we're not just one thing, that we're not described by one indicator, that we are complex beings with a lot of intersections that are beautiful and powerful, but also make us unique and really interesting to be part of the world with, that the complexity is part of understanding how the public health perspective in this work has to be lifted up and has to be operationalized and has to be seen and put forward. And that means that we do things differently, understand things differently. Now, I was talking about weariness, and I'm talking about so many things overloading us, the import and impact of oppression and racism around us. And I've been thinking about this lately, and I just want to say this thing because I think it's very true. I think that oppression is not like gravity. I think that oppression is not like the force of gravity. I think that when you think about oppression versus liberation, I think that it is harder to hold someone down than it is to lift them up. I think that it's easier to lift up our fellow human beings than it is to hold them down, which means that the work of liberation is actually less work than the ongoing work of oppression. That the work that we do to support each other is part of lifting us from our weariness in a way, and part of freeing us from what is a deeply powerful force weighing on our shoulders. This is important because in that work, it reveals the kinds of things that we should be doing and understanding. If you didn't hear and feel a sense that belonging is one of the keys to navigating the equity journey in this time, then I just want to say it out loud, that with belonging, with intentional belonging in the work and fabric of every piece of our work, whether it's legislative or business-oriented or philanthropic or healthcare or educational, if belonging is one of your key goals in that work, you are going to be that much more successful, and it's going to intersect with that much more around you. If we think about understanding as a key goal of actually seeing each other, and again, I've seen so many ways in which what you've talked about today is about seeing each other, we'll move so much further together on this equity journey. If we understand beauty and ability and strength and talent and brilliance in ways that are different than the way we've talked or seen or described them before, then our equity journey will advance that much further. If we lift up the key values of family and understanding the integrity of family being so important to the work that we do together, the understanding of connectedness of family being at the root and heart and soul of the best work that we will ever do, then that work will reach the heights that we hope it does. And when we understand that we are fighting for the rights of people to exist and live in the spaces and places where they are absolutely, then our lives begin to transform. And this is a battle that is going on today with such intensity, right? That Texas is is trying to decide whether or not they're going to criminalize parents who support young people in their gender identity journeys. And when we are talking about that level of fundamental threat to individuality and group identities and the opportunities for young people to know who they are, we're talking about a serious issue indeed. We have to work within our spaces in a way that allows us to be ourselves and do that work fully with our full identities, with an unapologetic ability to show up as who we are, not as who someone might expect us to be. And I say that as a person who grew up in the era of really having to cover my face, having to change my identity, having to be twice as good, having to be able to perform in a way that is not part of my cultural identity, but part of the majority identity around me. And if we are truly making progress in this equity journey, then we are inviting people to show up, not just in relative proportions of diversity, but also in deeply authentic and real expressions of who we are as people, what we bring, and how we think differently and better, and sometimes more creatively than the structures have historically allowed. It also means that sometimes we have to question our own narratives. And then we have to talk about the idea of multiple narratives and the power of multiple narratives and stories. America is really good at denying other narratives, and it's also really good at imposing narratives on communities. I'm going to be embarrassed and maybe controversial and say that this is an example of a narrative that I think has existed in the Black community that I have known for a long time. That almost Martin Luther King-esque idea: if you can't fly, then run. If you can't, then run, then walk, et cetera, et cetera. If you need to crawl, do whatever you need to do to keep moving forward. I used to think that was a really inspirational statement. And now I wonder, would I ever be asking someone I cared about in my community to crawl in order to move forward? Why are we talking about us needing to crawl when it should be systems that should be changing? Is this a narrative that we've adopted and brought into our lives and endorsed in some way that's really harmful? Do you have narratives in your communities, in your stories, in your families that are worth actually wondering if they're contributing to the issues of inequity and racism and oppression, or if they actually are the language of liberation that we hope they are? I don't know, but I hope you're questioning. I hope you're thinking. I hope you're acting. I hope today has inspired you to be moving in your space on this equity journey, because the greatest harm that we can do is to do nothing. The greatest pain, the greatest evil in so many ways to me, the thing that made me leave the hospital that I had dedicated decades of my life to, was not just the harm that was done, but the awareness of that harm, and then the choice to do nothing. The choice to do nothing. I think we need to talk very seriously about our own roles in that space and how we move from our complacency, complicity, into opportunities to plot and plan and strategize and organize and mobilize and move forward, because then we're starting to talk about switching power. If I had a feedback moment about a lot of the things I see around equity plans and strategies, I would say, I wonder if we talk enough about power. I looked again at the proclamation that you're one of them, that your community made, and it's so great about the ideas of training, the ideas of lifting up communities, the ideas of scrutinizing policies. Those are all really good, but without accountability to leadership, without leadership understanding their need to be able to share power, without a specific conversation about power and how power will be shifted, I am worried that these will all turn into good intentions, but won't turn into important changes. So I wonder how to be more explicit about power, how to talk about power when we're talking about equity. And if we're not doing that, I'm not sure we're doing equity. Just something to think about. But I do appreciate the way the language of your proclamation and the work that you're doing is really about centering communities and really actually being led by the communities most impacted by the harms. And without being led, not just engaging, but actually being led by the communities most impacted, beautiful, beautiful things have the opportunity to happen when you do it in that way. And when you start to think about communities as powerful, not as deficit filled, not as having this rate of this disease or this change in this kind of health condition, but as powerful entities then you start to talk more creatively about what the solutions are. Don't you? You talk about what's possible instead of what you're just trying to eliminate. And when you start to see that beauty and that power and that possibility, then you start to see how much we all can grow and learn and live by the celebration of not only our own cultures, but the cultures around us that have so many things to teach us about a different and more beautiful way to see the world. And when you start doing that, you start to be really cognizant of the ways in which we've limited our opportunity to understand wisdom and information, how much more the power of wisdom can enter into our lives, into our professional lives, into our work, and change what we do with some great, beautiful, incredible motivation and import. When you do all of that, you start to see communities as brilliant, as abundant, as full of promise and power, rather than communities full of deficits. When you understand that communities have everything they need to be great. I see so much of what you've talked about today being part and parcel of communities talking about and solving the issues that they're facing with the people, the resources, the strength, the power, and the energy that they have and they hold, the local solutions, the local ideas, the local import, the local infusion of investment and understanding. It's an incredible thing. If you started every meeting, every city council meeting, every board meeting, every health plan meeting with a sentence, something like, based on what we know about the brilliance in our community, we should be doing X program. I just wonder if you would have different conversations. I think you would. I think you would talk about how you would build the beloved community that you're working toward, and maybe in addition to, but more powerfully than just talking about the scourge that you want to move away from. These are important things to talk about. And I feel like in the heart and soul of the conversations I've heard today, there have been these three themes that keep bubbling up, whether they're through systems, whether they're through personal, whether they're local, whether they're across boundaries, the idea that we have abundance, more abundance than we often give ourselves credit for, that there's an incredible amount of abundance that we can tap into, that the importance of dignity is the kind of practice that allows people to be seen, see themselves, know themselves, and through that kind of energizing, be able to really move in directions that are determined by them, not by them relative to some other person or community, but by them themselves. And that the sense of belonging allows that to also feel like you're doing something in collaboration and cahoots and connection, in conspiracy with other people who see you and love you and care about you. And that is beyond a set of strategies. That is a campaign. That's a movement. That's a change that is incredible. I see examples all around. I just wanted to mention, I was up in among the Swinomish a couple of years ago and had a chance to see not only that all of these things are great ideas that sound good on a slideshow full of murals, but that they're actually physical spaces and places showing examples of doing incredible work. You described a few of them already today. Some of your speakers did. I'll add to that list the Swinomish Substance Use Disorder Treatment Center, and what it really means to revolutionize the idea of care and treatment across the boundary between healthcare and the intersection with it and community. And the ideas that are lifted up in this Swinomish Wellness Center in its work to treat substance use disorder is the kind of thing that the rest of the healthcare system should be emulating. In fact, the Swinomish also have a dental mid-level provider program. There's the kind of thing that the rest of the healthcare system should be emulating and building upon, and yet somehow through politics and power games doesn't seem to be able to. My point is that there are examples of beauty and power and change and transformation. There are pieces, markers along the way on this equity journey that teach us things that are really important if we pause for a minute and look up and try to see them. And when we do that, what we see ultimately is that their work is our work, and that we're all in this together, and that we are better together, that your courage is actually something that I borrow, that your strength and brilliance is actually something that is a gift to so many others around you than you'll ever know. And when we understand that kind of connectedness, I don't think we would make some of the same decisions that we've made historically about oppression and marginalization. And that's just what I wanted to share with you today. But what I mostly wanted to say is that you have so moved me today with your thoughts and with your ideas, with your expressions, with your sharings, with the personal expression of the work that is so important to each and every one of you. I'm moved and I've grown, and I hope, thanks to you, that I will be a better person. Thank you for letting me share some time with you, and I hope at least you saw some cool pictures. And if not, I hope we have a chance to share some more expressions of joy and power and success and brilliance on this equity journey.
Wow, Dr. Danielson, thank you so much. I feel like as I was listening to you, I just was writing down piece after piece of things that I wanted to burn into my brain and not forget, and the list just got longer and longer. I want to give a moment for folks to put questions into the chat, and I know we have one question already, but in the meantime, I just wanted to repeat a couple of the things you said that really stuck out to me. One was that in healthcare, we're not ready for these conversations. People still aren't comfortable talking about race. That's something that I feel like I have been feeling this whole last year and planning this conference. And I can say I would love everyone around me to start being more uncomfortable or more comfortable with being uncomfortable with this. And I hope that my colleagues can leave today feeling like we need to change the fact that healthcare is not ready to talk about race. So thank you for highlighting that, the need to normalize these conversations. The idea that it's harder to hold someone down than it is to lift that up. I mean, what an inspiring idea to think about with every single one of our patient interactions, how we are lifting them up with every single one of our clinical assistants or colleagues or administrators, how we are building them to be better together as a whole and working toward this shared mission of good healthcare. And then the idea of belonging as a key goal. I mean, I think so often as a white person, I walk into a room and I don't have to think about the color of my skin, particularly up in Bellingham. And it would be a beautiful thing to see a place where every single person could walk into every clinic in our community and not have to worry about whether or not they belong. And then the idea of real change versus symbolic change, that seems like such a hard place to move from. And, you know, when you mentioned the idea that, that you can choose to do nothing and that you need to move from complacency to complicity. And, you know, in medicine, when we choose to do nothing, we call it expectant management, and people, we decide to do nothing. But with anti-racism work, it's the default. And I think we need to be more intentional about when we do nothing. Okay, we are not here to hear me today, so I want to move on to questions. The first one is from Dr. Ying Wu. And let me see where I pulled it up. He said, please ask Dr. Danielson to say more about the weaponization of time as an instrument of suppression. How can we recognize and resist this and turn it around?
Briefly, I think we have to fight for time. We have to fight for our time to be present and connected to the people that we care about, whether that's working with a patient or family or talking to each other about the struggles and the successes that we have in our work with each other. Time and the number of things we do cannot be the measure of how we are identified in our professions or in our work, or how we are understood even from a business model. It's a bad model. It leads to bad outcomes, which we've said that we don't want to see. We have to fight for time. And I don't mean like proxies for time. Sometimes it's fill out this form first before the visit. Those things can actually have adverse implications for actually being connected with people and actually sitting with them and talking with them. We have to be champions for time. And I think championing time is an anti-racist approach. So if your organization says it's going to examine its policies and it's going to be thinking about how it can do things to be advancing equity, I think time should be at the top of the list.
Thank you. The next question is, can you give us some examples of using data for positive change and somewhere it has been used to thwart positive change?
Well, again, I think our systems are very understandably set up to look at the power of numbers. And I'm not saying anything new that anyone else hasn't said before, but the power of numbers then implies that the small numbers are people whose lives are less important. And we have not yet devised, I think, really good ways to really say that the experience of a few people is actually important enough to us as a community or as a society to respond to that. And so you see these times again and again where we either aggregate people into crazy categories like Asian, which seems to cover such an incredible area of ground that it becomes meaningless in its idea as a category, to the ways in which groups like missing and murdered Indigenous women could be a horrible set of actions that are continuing. We don't pay any attention to them. In other ways, I've seen the ways in which disaggregation has been a really powerful way to understand, to really see that the displacement of land has happened in the Marshall Islands as well as on this continent, thanks to American colonialism and manifest destiny, as was talked about before. And that understanding that actually reveals the needs of a community that is really a powerfully wonderful part of our society. I've seen where the control of information in communities, rather than at the level of the person publishing the paper, has led to a whole different level of power in dialogue with who gets to share it, how it's shared, who understands it, and who benefits from it. So I think there are lots of examples. There's no limit to the number of really great ideas out there. There's a greater limit on the amount of will that we have as a group of people.
All right, the next question we have is, what are some suggestions to build trust with providers, with patients of color, as I know issues with trust in this population are one of the issues with patient engagement?
So this is work that each person has to do. And there are times when sometimes a question like this, I think, is really well intended. But I also want to talk about the lack of shortcuts to really getting to spaces like that. This is related again to me to the idea of time. I don't think you can even ask that question without having afforded the kind of time that's necessary to actually bridge, without having the ability to have language and dialogue in a profession that doesn't seem to really want to talk about it as a system, at least. So those ingredients are really key. And the last thing I'll say about this for now, because I could talk for hours about this, is I'm troubled by the idea of how can we gain trust, because that feels very extractive from communities to me. How can we need to make them trust us is a sort of sentence that sits in my head. I think that what we can own and control is doing things that are trustworthy, and that we should commit ourselves to trustworthiness. And then as human beings in society, in relationship with each other, communities and individuals and communities get to decide whether to trust us or not. We can't ask how we can make people trust us. That's really fraught with imperialism in some ways to me. So I think the better question is, what can you be doing to be trustworthy? And I think actually all of us have really good answers to that one.
All right. Next, thinking of this session being predominantly providers, do you see differences in race, equity, and social justice as we have new generations of providers joining the workforce? This is from Liz Baxter, and she says, my hopeful thinking.
New generations of providers, yeah, absolutely. I am so inspired by my mentors who are younger than me, and what I see in them. I saw that in you, Erica, but I won't go there right now. But is this different kind of energy, and maybe more importantly, in the medical students I see right now, like the Black medical students and the brown medical students, is the expectation of something different. I think I was trained to survive something bad. I think in between there is sort of this, let's create some hopefulness about the possibility of something different. And I love like full-on audaciousness of students today who just say, we fully expect it to change, and we expect you to do your part to make sure it changes. That's a different kind of thing. And I find that that gets me off my seat. That pulls me out of some of my complicity and makes me also really, really enthusiastic about the future. I hope we never squash the spirit of a young person who's saying, I expect change. I hope Black and brown elders never say, oh, hold on there, I had to suffer, so you have to suffer too, kind of stuff, because that's us dragging our people down. I hope what we really do is respond to that energy and that power and be lifted up by it.
And I loved the quote that you shared during your presentation. I'm no longer accepting the things I cannot change. I'm changing the things I cannot accept. So.
That's right. That's a fist in the air kind of statement, isn't it?
Okay, next, regarding the oppression of time, can Dr. Danielson speak to the utility of group health classes to help unwind systemic disease and systemic racism?
Oh yeah, I think there's so much great benefit in that opportunity for folks to sometimes be in community with each other in talking about their health needs. What I think is more important would be to go to a community and ask them what more meaningful time with their provider looks like to them. Because it's just this little risk of us sort of creating a whole bunch of solutions that sound really great to us, and we could justify them and have lots of good reasons. Maybe the community would say, yeah, we want group visits. Maybe they would say, yeah, we need the whole family in the room for decisions about an individual, and that we would have to respond to that. But before we start designing things, let's make sure we're asking those most historically negatively impacted by oppression.
All right, thank you. I'm just going to look back and see. I think we've made it through a few of our questions. I'm going to see if we missed anything. Lots of just thank yous. There's one comment that I am not going to be able to do justice to. So I'm going to ask if the individual who wrote something in a different language that I cannot speak, I'm scrolling back up. Someone asked me to write something to you that said, thank you, Dr. Danielson, for your wonderful talk. And they included it in both languages. And I was going to give them the chance to speak it outright, but I can't find it. So if I can find it before the end, I'll bring that back up. Otherwise, what other questions are there?
Joel Hilaire Jr.? Is that who's?
Yes. Yeah.
Said Dangan Skitla Oyagang, thank you so much for your words, for your time today. Thank you.
Thank you. I appreciate you. And thank you for sharing that.
Okay, I have another question that came up. This is from Elizabeth Gabe. She states, how do we create an environment where it is safe and easy to talk about these issues in the healthcare environment?
To me, a lot of that is a leadership issue, which is again why I don't always see leadership brought up in these ideas around equity and the response to inequity that we have. We have a lot of things about looking at policies and doing trainings and this and that. But that question, I think, is so deeply connected to how leadership not only creates a culture of encouraging that kind of conversation and that kind of vulnerability, but also ensures that there is no retaliation that would come from those conversations as well. I think this might not give me an invitation back to y'all, but I think we still do a whole lot of protecting white male leadership in organizations, and we work all the way around them to do everything else. In fact, we put a whole lot of work on the shoulders of women, Black and brown people to do a whole lot of change making, but we don't ask leaders to change. And I hate to get systemic with what it was a very specific question, but I really hold leaders accountable to actually making sure that you don't have to ask that question about how will it be safe for me to talk about this.
That bridges directly actually to another question that just came up, where this is from an internal medicine at Skagit Regional, internal medicine resident, and he states, how can white people like myself decenter whiteness in the healthcare setting?
I think asking that question is a really good start. And just like you had said, that just realizing that, wow, I get to assume belonging and that, you know, the dial norms to me in every space I'm in, understanding that that is one of the sort of deepest parts of inappropriate privilege is something to start with. And I think that starts a conversation. I think also that a tenet of equity to me is that the solutions around inequity are best designed and named by those who face the most inequity. So if you see yourself as somebody, I'm going to use your words, sort of white and privileged, then I don't think you should be naming ideas for change or solutions within your organization. I think you should be supporting the making space for other voices that have been historically oppressed. That could be people within your workspace, and it could be people within the community you care about. If you're doing that and you're listening, then I think the solutions will flow.
All right. I'm just going to share a comment. Thank you, Dr. Danielson, for sharing your wisdom, truth, and your gifts. Your legacy is rooted in love. We are just about
Wow.
we are just about to the end of our time. I did want to give one more scholarship update before we wrap up. It looks like, thank you to the combination of Dr. Danielson's contribution and everything else donated by attendees today, we're at a total of $17,379 raised. That's all going to go directly to BIPOC trainees in our community working towards becoming part of our healthcare force in the future. So that's a really exciting thing. And I know I can't wait to see kind of who the next round of scholarship applicants are. Dr. Danielson, before I do some final wrap up comments, any final comments or anything you would like to close us out on?
Investing in your future, like that scholarship program, is the best example of not being complacent in my ways, in my thinking. So I think that is powerful. There aren't that many convenings or conferences where one of the discrete and expected goals, even as part of the conference, is to be able to invest in the future of the workforce and the spaces and places around you. So that's incredibly moving. And I hope you all just do yourself, like hug yourselves in a way, because this is the kind of thing that other conferences and gatherings should be learning from. I'm so honored to have been in space with you. And again, I feel like the least voice among many incredible voices today. The way this was brought together and the way that it expressed itself was really a transformational experience, I think, for me, and I hope for others as well. So thank you.
Well, thank you so much for joining us here for today and all of your words, Dr. Danielson. All right, guys, it is just about 2 o'clock. We need to get you on to the rest of your day. Thank you all for joining us. Thank you for your time and energy. Thank you to the generous donors and community partners. Thank you to our sponsors. I just want to highlight again, Chuckanut Health Foundation, Family Care Network, North Sound ACH, Skagit Regional Health, Northwest Washington Medical Society, and Peace Health. All of those organizations contributed funds to make this a free CME event so that we could lower all the barriers to keep anyone from attending. This conference is approved for 4 hours of free CME and nursing CEUs. So if you want to get that CME, please click on the link in the chat box and fill out the attendance evaluation survey. We also really welcome any feedback, comments, questions. Our goal is to make this an event that is useful to our community, that is listening to what we hear from everyone who's attending as to what we can do better, what we can change, what we can expand on. I feel grateful to everyone who was involved in planning everything. This has been a huge team effort. It's 2 o'clock. Let's wrap up. Have a wonderful rest of your day.
My lunch king, take care.
Thank you, everyone.
Thanks, everyone.